in person and also online. So it's a hybrid. And it's great to be in person, but I know people have commitments. We'll get together and that's good. And just to say that we would, as we always do, we start off with a patient story and service user with it. Very valuable, but unfortunately, right at the last minute, ill health is here, so we won't be having that session today. So what I suggest is we start on time, and then we'll just read all that 5 minutes to see how we go, because we do have a bit of space for that. It's a very big agenda with some really important items on it. So just some administration. So we will have some contributors to talk about some of the papers that we have. Really nice to welcome Adrian, who's one of our governors, joining us this morning. I want to just sort of get to know a little bit more about what's happening. So hopefully we'll do the trick for you. Kevin, Kelly, and our non-executive director, they're coming in online. It's your last board meeting. We really must recognise, acknowledge that, and thank you for everything you've done over the years, the Sussex Partnership Foundation Trust. You've been an excellent non-executive director. I've only had the privilege of working with you for a year. I've enjoyed every minute of it. I thought you've been very loyal, committed, and got a real heart for the organisation. And all your work you've done around quality and the Mental Health Act has been extremely significant. We're really grateful. So thanks very much. And just to acknowledge this is your last meeting.
Thank you, Chair.
Yeah, very good. Declaration of interest. So that's fine. So the board held on the 5th of February. Actions and minutes arising. Just to seek approval of the minutes. Yes, Teresa.
One point for me, Chair. On page 5 of 7, in relation to health and safety report 11.1, that should read the health and safety executive MSK and violence under question.
We'll make that clear. Thanks, Teresa. We don't have any questions from members of the public. Right. So we move on to the chair's report. Well, I have just come back from 2 weeks leave, and the day I went on 2 weeks leave, there were all sorts of announcements about the NHS, and they were very, very significant announcements. And I felt a bit guilty about going off on annual leave, but we've had transformation, we've had service changes for many, many years, and I've been involved in all sorts of this is, though, however, very significant. And I think it would be wrong of me not to mention, just to give you some updates. Jane and I were called to a meeting with the new Chief Executive, Jim Mackey, and Amanda Pritchard was there, along with various other people leading the health service in this country. As always with these things, a lot of it will be in the detail, and a lot of it we need to work out. Of course, the main headings were, 50% reduction in integrated care boards, NHS England being acquired by the Department of Health and Social Care. So I never not allowed to use the term abolition of NHS England, but a significant change there. So moving NHS England into the Department of Health and Social Care, and various. I mean, I think start from the top. Really, that there is a global economic pressures. There's certainly economic pressures in this country, and there are all sorts of needs to look at public spending. And we've done well in health over the years. Other government departments have had to make some very radical, significant savings. We've had to do our bit, but by and large, we've been protected in health. We won't be now, and we will be needing to make significant savings. Now, most of this will be in layers that we report to the Integrated Care Board, Regional Office, and NHS England. I think we have to say as a board that some of those functions, if and when they go, what we need to be aware of is that some of that will trickle down to provider organisations as well, because a lot of that work will still need to be done. the integrated care boards will have to make some savings and they'll have to functions. Now that will have implications for us. So we just need to be very aware of that. And we'll be coming back to that in this meeting and various meetings over the next couple of months. I would say, though, that we are an organisation that's strong, that does tend to have a good eye on horizon scanning. Not that we saw all this coming, but it's no surprise that we have to look at our costs and efficiencies, and now we stepped up a little bit. We of course done some really good work on that over last year. We have a significant. We are in the middle of a significant financial recovery. Year one, it has to be said with great pride that we have breaking even. We've achieved our target. Next year it will be more challenging. More about that later in the board meeting. But we've been looking at our costs. We've been ahead of that. So some of that work that we will need to be doing from NHS England has already been done. I was at a meeting this morning, a very early meeting with the Integrated Care Board to talk about some of this implication. So those discussions are happening already. And chief execs, we have to involve the chief executive, which was said on a number of occasions this morning, and we will. And collectively, we're a good player within the system. And we've always, the integrated care system, we've always prided us, had some pride around that. And I think it's so important because going forward, a lot of what we have to do will be play our part with our system partners. And I suppose the other thing is that, alongside this happening, we've got the local authority, significant changes with the, where we put a proposal in, a bid in, and it's very likely that there'll be a mayor of Sussex at some stage, not too. And there are real opportunities for that. So I think everything that we need to do regarding transformation of services, changing our services, we need to be doing with an eye to working more closely with local authority. Just the rest of it, I will leave as the report, but I really wanted to say that we have a new lead governor, Sarah Payne, and a new deputy lead governor, Catherine Eastland. You'll know that we've been engaging our governors more. Thanks very much to Keith, who was lead governor for many years, and thanks for all his work. We now have a new lead governor, and we're going to be working closer. Board and governors be working closer, and that's going to be really, really good. And I'm very grateful for them. So you need to say the board of directors appointments to Simon Blake. Simon Hello, appointed as deputy chair. Linton Netters reappointed as non-executive director, and Aviola, she'll join us shortly, appointed as non-executive director because she was previously an associate, and Colin appointed as a voting board member. I think I'm going to leave it at that. The other points I mentioned to the report. Very happy to take any comments and questions.
Hi, just a clarification. In your report, you mentioned Kevin Jackson. Is that sort of misprint for Keith?
Keith, I think I was referring to Keith Dinesh. He's the lead governor, former lead governor.
But it sort of, I thought there was maybe a spelling mistake about sort of Kevin Jackson, that's all.
It's a typo which we will attend to. Yeah, I'm referring to Keith. Thanks very much, Dinesh. Yeah. Anything else? Thanks very much. I think it's the chief executive.
Thank you very much. So as Sean has set out, a lot has happened in the NHS. Some of it is in my report, but it's, as you will appreciate, it's been a fast moving environment. So not everything is captured in the report. But what I'd say is that the Prime Minister announced that NHS England will be brought into the Department of Health and Social Care over the next 2 years. That will require some legislative changes. I can't say that word very well. Integrated care boards are required to reduce by 50% in Q3 this financial year. And at the same time, we have been asked to reduce our rate of corporate costs since the letter came out this week, since it's benchmarked against 2018. And we still haven't had the technical guidance attached to that, so that it's still, I think we've got some guidance and some indication, but not full clarity yet around what that means for us. But we are working through the different options so that we can respond to it appropriately. As you'd expect, there is a lot of work happening through with the practical implications of that. It's happening at a rapid speed. So diaries are having to change very quickly so that we can be, whilst making sure we run the organisation day to day and make sure that we can maintain safe, effective and care that is a good experience. All that said, and most important of all, is that we remain continually focused on improving quality on behalf of the community we serve. I think that's really important that we have that in mind. And one of the things I've been thinking about is that we just need to remain steady and hold on there with this. We need to really remember why we're here, because there's lots of things that could buffer us and could derail us. It's important we keep that in mind. Structures in place within the NHS are really important, and they are because they support the delivery of the care for our patients. And that said, we must make sure that we don't become distracted from the patient care by these structures, and we need to stay true to our values and deliver the changes that are needed in a values-driven way, and use it as a catalyst for the continuous improvement. I think it is important to say that these changes have been announced within the context of the NHS as a whole, not living within its means financially, and we are stewards of public money, and we have a duty to do that as well. And I think that's really important to say, because we need to focus on quality, but also delivering financial balance is quality as well. It's not something that's separate, and I'm really clear about that. We have a public duty as public servants to be good stewards of that money, and that means it's important for us more than ever to be clear and concrete on our thinking about how we use our resources to maintain quality. But with that in mind, I believe it's really timely that our new 5-year strategy came into being on Tuesday, because we're now day 3 into the strategy, and we have a really clear delivery plan and clear objectives for the next 5 years. And they are not misaligned with what's happening nationally. We have financial sustainability in there. We have environmental sustainability in there. We have high quality care. We have looking after our people. They're all in there. And so I think we have a good bedrock and foundation, building on what we did last year as well, to actually face this head on and be good system partners as well as good advocates for our population. The patients and partners and staff who helped us co-produce this strategy will expect us to translate that into practice for our patients, and it's our responsibility as a board to hold to that. I won't go into everything that's in my report because it is there, and it's there. We're going to talk about the staff survey data, and Zoe's standing here for me today, who is on leave today, so she's not able to be here. Zoe is very kindly representing me at board, and we'll be talking about the staff survey in depth there. We have some learning from what has been said in that survey and some improvements to make. 2 other things. One that I'm going to hand over to Usman, but just briefly, because we've got a consultation out nationally at the moment about performance framework for trusts, so performance responsibility, and I've asked Usman to just give a quick brief of what that means for us and how we're looking at. And how we'll involve the board in our response to that consultation. But I sort of wanted to end on a good note. We won an HSJ award for being the best mental health service provider 2025 for our provider collaborative work in partnership with ORI in our eating disorders service. So very proud, and thank you to Colin and the team in the provider collaborative for the work that they've done that resulted in the national recognition. I'll hand over to Usman and then we'll take questions.
Thank you. So just briefly, a new statutory oversight framework has been issued by NHS England. That will go out for consultation. Date's exactly wrong, sorry, I can't put it up in front of me. I think it's from May 2nd to May 23rd. It will be open for consultation. What we're doing at the moment is we'll produce sort of a summary of what does that sort of mean in terms of for us as an organisation, in terms of what reporting look like. Are we covering off everything that's within that soft framework? Are there aspects within that new oversight framework that we will need to adapt to make changes to? So we'll generate a summary for you. We'll then send that out to board members, and we'd be really keen to get people's feedback on that. And then our aim will be to consolidate all of that feedback into a single trust response that we'll then put back ahead of the end of the consultation period with a view to. So that's all there is really to say about it, other than it's out. There's no need to go looking for it for links. Don't worry. When we send out the letter, we will attach a copy of what the new framework says, plus the links to what the old. Don't worry about trying to go.
Any questions for Jane?
This one, I mean, I'm sure, you know, just thinking about the context for all of this, do you feel that centre is giving enough focus to in the news today, you know, children in poverty, an increase in the number of diseases associated with severe poverty? And although you could argue that that's not necessarily our focus, I think it is a focus nationally. I just wonder if that conversation is being kept alive and front of mind. You know, in the midst of all the changes, it seems to me that the people who are going to suffer most from all the narrative, financial changes to the NHS, the people who are going to suffer most are those who have the least. And I wonder whether that's something that is.
But I'd answer that in two ways. One is, I think we need to be mindful that Penny Dash, as the chair, so it's very early days to know, and I think that's a real thing. But my indications would be Penny Dash is very focused on quality and population health, and I think she has a very strong view around that, is what I'd say. I think time will tell. I think for us, it's on us as system leaders to keep that in mind locally. I think we can be reliant on the national, but actually it's on us as a board to keep in mind population health. Representative on the board of the ICB to keep that in mind. We've got public health representatives on the NHS Sussex board looking at that. So locally, I feel that we have a strong presence. Mind to keep bringing that forward. Nationally, I think it's too early to say.
We're members, of course, of the NHS, the Federation of Election Providers, and I know that they're all over this challenge. For people who need our service. One of the should not get lost, but we're going to have to play our part in. So you're right to raise it.
And what's going to be some point of really because it is a system together changing series.
I can't really hear you.
Oh, sorry, so I stand out. So
the air conditioning.
yeah, so just saying the concern about the role of the ICB as the system convener, which very much talks to the issues that Anna was raised around population health management, health inequalities. And there's some sort of sense that with the reduction that's required, they might get larger, we might see mergers of ICB. And that might not align with the agenda that Sean referred to, the Devo agenda, wherein the guidance about devolution, potentially the elected mayor could be the chair or the co-chair of the ICB. They start getting much larger there's potential for that sort of misalignment and missing those opportunities of bringing the public sector together in the geography. So I think there's a few things the dust has got to settle over it. And my second question really was about interesting to hear that the baseline for corporate spend reduction on providers is 2018. And presumably we would be optimistic that the work that we've already done would get us to where we need to be without any huge further inroads. Question. Or is it too early?
Maybe if I ask the first one and then Elizabeth, you have the answer in the second one, because we've been talking about that and he can say, oh, I'll go here and leave the night. So on the first one, I think it's too early to tell. I think they're all things that are being talked about at every meeting I'm at the moment. My view is we need to think strategically as a board what our preference would be and be an active advocate for our patients in this space and for the population in this space. We could passively just sit back and watch everything happen around us, or we could proactively be part of that change and see how we can support the system, how we can be a proper system player, and how we can actually lean into it. My view is doing the leaning into it and being a proactive partner in making sure that this is a success, however it lands, is the approach that we should take. But I think it's something as a board we need to come around and think. As I say, it's such early days at the moment, and you said, like you said, the dust needs to settle. But I think we do need to think about it.
On the second question, so I'm conscious also Kevin's got his hand up, but on the second question, so the 2018-19 baseline is a challenge for us, and it will be for most mental health organisations, because that is the year also when the long-term plan investment that went with it started. So as Jane said, it's only just come out at a very high level in a letter. We've had no technical guidance and there's been no discussions about it. So I wouldn't want to make any speculative comments on it at this stage. I think it's too early to say. I think the work that we've done will mean that whatever that reduction looks like for us should hopefully be a bit easier than it would have been if we hadn't done the work already. So we won't have as far to go, and the change hopefully will be less dramatic than it would have been otherwise. But at this point, I think it's still, there's a lot of questions that need to be answered in terms of the detailed technicals.
And it's right to be lazy, so it's about preparing ourselves for what's coming. And I think that's a good answer. Okay.
It's one of the perils of hybrid working, isn't it? That the conversation moves on and you're kind of going, hello. It's kind of tricky. So I kind of come back to the question that Anna raised about how we can play our part in health inequalities, what more we can do, and how we can keep an eye on what's happening nationally. I think there's often a confusion, isn't there, between health inequalities and healthcare inequalities. And very often the systems we're involved in are looking at the provision of healthcare without being able to get at the underlying issues. And I think you're right, Sean, to point to kind of devolution and how local authorities and the wider system of investment in at-risk communities can be sort of kind of trained, if you like. And I guess for our part, it's about proportionate universalism, isn't it? It's about our ability to be able to focus our resources on where it's most needed and kind of point ourselves, both as systems leaders and as providers, towards those areas. And I think there is something, quite a bit of the strategy about that, about how we do that over the next few years. So I think it's not about being passive, it's about actively using our resources to address what we see in our populations and to proportionately put resources where they're needed.
Thank you, Kevin. Okay. Thumbs up here. So moving on to the board assurance framework, we had a board development day on risk and the board assurance framework, and I think really this is about the documents about taking the action from that. Yeah, an update this one, please.
Okay, so just to, I guess, cover off the sort of first bit on this. So you've got the BAF as standard attached. All I'll draw attention to is, as you probably expect, coming towards the end of the year, there hasn't been significant changes from where we were last time we met, with the exception of BAF Risk 09 related to operational performance, which has actually decreased in risk. So it's gone from 20 to 16, and that's largely on the back of improvements in our CRIFD, so clinically ready for discharge position, but also really successful work in the CAMS waiting times, and in particular the significant reduction we've seen and sustained over the year in 52-week waiters. So that's specifically in terms of our BAF for this month. So there have been no material other changes in terms of risk scores. I think it's worth saying that probably change as we enter the new financial year. And we relook at it in our effort to make sure this maintains as a live document reflecting the most accurate positions as we sort of go through it. The bit I guess then just want to draw people's attention to is, I think most colleagues, but for those who weren't, we had a board workshop where we spent the whole time basically going through really examining our BAF, what it means, what it looks like. And I think it was a really, really great session, to be honest. I think it was really interactive. There was lots of interest, lots of engagement. And I think with the help of our colleagues from RSM who helped run it for us, I think we realised that we probably need to retake a really fundamental relook at our BAF, aligned to our new strategy, and so make sure that the board is really focused only on those strategic risks that are a challenge to the delivery of our organisational strategy. And therefore, what we've set out in the paper is a sort of a bit of timetable around how we're going to go through that process, the sort of various stages, who's going to be involved in that. And as you can see, it's a relatively tight time frame. We're trying to do this pretty quickly because we want that back up and running sort of sooner rather than later. So I won't sort of go through the detail of the timetable, but it's set out there, and I'm happy to take questions on that. And I think one of the interesting things that sort of was really, I came out of the meeting when we had the board workshop was, even where we think things are low risk, how are we really testing ourselves that the assurances we're getting, the evidence in effect is genuinely there, and that we don't just, I think one of the most interesting statements for me that came out of that session was, worry less when something is red because you've identified it as a problem and you're doing something about it. Worry more when everything is looking green, because how will you actually know that you've got oversight of it? And I thought that's something that we'll then develop into that thinking and incorporate it into the development of our new BAF. So I'll leave it there. I'm happy to take questions, Chair.
Yeah. I think I'd like to acknowledge the risk movement, the improvements in CAMS waiting times, reduction in patients clinically ready for discharge, and there's a lot more work to do, but going in the right direction. Okay. Please.
Thanks, Chair. I may have missed a meeting, so this may have been discussed there. Question asked and answered. So there's been a movement in risk in relation to we failed to deliver an effective operating model from 20 to 16. That's correct, isn't it? Just a good governance question. Presumably that was taken through committee. Is that right? Would that be quality committee?
So those are managed with John as the SRO through the ODGs, which is operational delivery group that comes through to the EC. So it was executive committee.
No additional sub board
no
oversight. Okay. All right. If I could just pick up on the point you made, Chair, about clinical validation programs and CAMS, residual score having been reduced to 16, is it not arguable in circumstances where the waiting lists in numbers and times have not been significantly, or indeed one could argue materially reduced? Treatment received remains later than is optimal. We know that perhaps that's something, and indeed we know that provider collaboratives, they are telling us that there's a lack of capacity in the system. With that in mind, it surprised me to see that there was a reduction in that score.
So I take the point. I absolutely agree. I mean, where we currently are in terms of wait times, and we'll talk about it more when we talk about the IPR, is not in a position where we want it to be. But I think, as we've previously demonstrated, a significant element of that wait list at the moment is what we would consider as through our NDP, and that's not to disassociate ourselves from it. It's absolutely a challenge. This specifically was related to the CYP non-NDP 52-week wait position, which significantly improved over the course of the year. It's still a 16 risk, so it's still very high risk. We haven't sort of said it's suddenly become a green risk. I think it's a really fair challenge, and we have a really close process for monitoring the waiting list program generally within the organisation as an exec sort of through executive-led groups. the driver for the change was to reflect the fact that while it's still higher risk, it's probably not as high risk as it previously was, because the 52-week waits in particular around CAMS was a particular challenge for us in the non-NDP element of the wait list. It also reflects that we've had again, sustained improvement in our clinically ready for discharge position as well, which has gone down from circa 90 odd to sub 70 over a sustained period of time. So it was a combination of factors. But I think it's a completely valid point. I think it's something we continually test ourselves on in terms of are we getting the balance of risk.
Brian just wants to add to that.
Thanks. Yeah, it's probably too much specific detail. And so I would echo Usman's comments. It's not, of course, where we would want to be. And whilst the focus is on people waiting for longer than a year in CAMS, we've also seen a reduction in the CAMS waiting times overall. A gradual initial reduction and the size of the waiting list, which is separate to capacity for inpatient admissions, because you mentioned the provider collaborative. That's a really significant issue. So this was specifically about CAMS waiting times. It's not where we want it to be. It's better. And I think to Usman's point, 16 still remains high.
With your forbearance, if I could, I've got very high. This relates, it's in your appendices 3. Thank you for that. And it relates to risk 4 on the tracker, that we failed to attract, recruit and retain enough staff. In October, I see from the graph that it went down from 16, the risk rating, to 12. Born of the staff survey results, that we know that there's high staff sickness rates, and that continues. Clinical workforce issues, and I don't need to tell you about that. And there are 5 gaps, significant gaps in workforce sustainability. That's BAF 04. Do you think we need to revise that? I know it was in October, but what we now know since then, not just, but in particular, the results of the staff survey, is that something we need to be mindful of? If not revise altogether, but be mindful where that's tracking at.
In light of what we know now and in light of the staff survey results, I think that's a very fair and reflective point, and I think there's an opportunity to recognise the ongoing transformation that we are undertaking, and to reconsider that. So I would be supportive of that position.
Kevin, please.
Just going back to, again, sorry, the delay with the going back to BAF risk 9, came in from 20 to 16, but it was the consequence, not the likelihood, that we adjusted. And I'm interested in the thinking beneath that. Why is it? Why are the consequences of a failure likely to be less now?
Again, so I think that's specifically related to the fact that the number of 52-week waiters has come down within the CYP, with the sense that if you're waiting longer, that's a worse consequence, and equally within the CRFD position, because that has reduced the consequences of high numbers of CRFD patients are always clear for us, where we see that reduce. The consequence of that changes. It doesn't change the fact that the probability of it happening is still high, because it is in fact happening. So it's kind of it is a subjective decision in terms of the work process you work through to balance that level out, but that would be the basis for it.
There's still an awful lot more work to be done here, but
I can think that's fine. Yeah, and possibly there's an element of a 5x5 matrix isn't actually sophisticated enough to capture this, right? Yeah, there's another dimension in this that isn't about risk or consequence. Yeah, okay.
But let's move on, and thanks, Usman. So our strategic plan for 25-26. Thank
you, Chair. So this brings an update to the board of the work that the executive have been doing in terms of mobilising our trust strategy, which, as we talked about, launched earlier this week. What we've sort of talked through here, so there's some brief information around. Obviously, we're in the middle of launching the the comms, the engagement kind of sort of piece, culminating in a launch event planned for the 7th of May, and Dan can provide any sort of further information around that. And then what we've provided detail around is in terms of looking at what the year 1 strategic delivery plan should look like. couple of kind of caveats before I just go into a little bit more detail about it. So I think this represents quite a significant change for us as an organisation in terms of how we are trying to transact our business. So this idea, and I think it's in, I'm going to get my appendices wrong, I think it's Appendix 1, about being really clear around what are our strategic objectives for the year, but alongside that, what are our organisational kind of projects and plans that we need to do? So I think one of the dangers sometimes that we historically fall into is that we try and shoehorn everything into becoming a strategic priority and don't differentiate between, you know, what's the true north that we want to really keep sight of as a board on a regular basis, and actually what are the supporting kind of programs of work and ensuring that they are aligned to deliver the overall strategy. And then recognising that that's being done in a kind of a context of change, and as well at a time when we are looking organisationally around implementing continuous quality improvement and really thinking about how to get that kind of PDSA kind of quality narrative central to everything that we do. You'll see in under sort of 2.8, so there was a range of different kind of engagement conversations, both with our senior leadership team, with broader colleagues across the organisation, and then several executive sessions where we have sought to identify what are the key strategic objectives for 25-26 that we would seek to be aligning to. Again, I will stress this isn't the totality of the work plan, but this is the, you know, the measures, if you like, that kind of come up to the surface. What we have tried to do, and obviously recognising that national planning has been in a sort of state of flux, is make sure that we are aligning to what fits within our strategy, and then also what are we knowing is a national priority for us this year. So you will see that there are waiting times in terms of admissions, the 12-hour waits. We know that that is part of national planning kind of sort of guidance. Length of stay is incorporated within that. Again, we're aware that there's a lot of focus on this, but we know that suicide prevention is one of our top strategic measures. So we cannot not have anything in here about suicide prevention, because that is our biggest local kind of sort of, or one of our biggest kind of organisational kind of sort of priorities. And then obviously there is the piece around SIP, financial sustainability. And then going back to the conversation that we had earlier on about population health, there's two elements within the measures for this year. One being around our data capture. We've previously talked about the fact that it's very difficult to evidence the kind of the equity of access, effectiveness, and experience if we don't have good quality data around understanding the protected characteristics of the patients that we serve, and also around the sort of the physical health check increase as well. So those are the sort of the key sort of strategic objectives. What we currently have at the moment is that all the divisional teams are currently working up the delivery plans, the trajectories that sit behind those over the course of the next 12 months. So how do we organise ourselves differently? Our organisational wide priorities and not just seen as the responsibility of the few. And then alongside that, then looking at how do we, alongside the conversation that we just had about the BAF, how do we then look at the oversight and the accountability that needs to sit through these? So actually, what is the reverse waterfall up to the board, if you like? So actually, which are the kind of committees that would take responsibility for overseeing kind of sort of which of these particular kind of sort of metrics, and then how does that then culminate in a quarterly update to the board in terms of the delivery plan against it? Wasn't going to say anything further. I think the two appendices at the back, so one of which, the first appendix, just aims to help give the sort of the structure that we're trying to kind of work to. And just for reference, we met with the SLT a couple of weeks back to try and ask them all to put, you know, what are all the big programs of work that you think we're doing as an organisation for this year onto the table. Helpfully and alarmingly, I think we ended up with in excess of 80 different projects that our senior leaders thought were trust priorities for 25-26. Helpful because at least we had them all on the table. Scary because there's something about us needing to do a really rapid piece of filter work, because clearly we can't do that simultaneously. So actually we need to help support our senior leaders to really think about that sort of streamlining approach. And then actually how do we collectively understand and prioritize what is most important, and the sequencing of those things dependent on resources. But I just thought I kind of gave the board a sort of slight flavour as to the exercise that we're trying to do. And then the second appendix, which apologies is slightly blurry on here, I will get it recirculated to colleagues, just starts to try to look at actually how we're trying to do the mapping across, so that we're not just looking at a year in isolation, but we're starting to think about some of those interdependencies. And the need at this stage to really make sure that we're kind of getting the foundations right, which again I think aligns with quite a lot of the conversation that we're hearing nationally as well. The bit that probably doesn't feature in here, but absolutely is featuring within our kind of organisational kind of sort of plans and stuff, is the piece of activity. So obviously it's not sitting within this, but that doesn't mean it's not important. It doesn't mean there isn't a work plan being developed that will sort of sit behind it. Actually, I'm happy to take any questions or field.
Yeah, thank you very much. Kathy and Dan.
Yeah, so thanks. I thought it was really helpful and really good to see it coming to life really for the first year. On Appendix 1, this is my understanding, I struggled a bit to differentiate between strategic objectives column and the organisational projects column. They look quite similar to me, and I haven't quite worked out what the difference was, or is the one.
Yeah, so the strategic objectives are the things that we've said, okay, in line with our key strategic priorities, what are the things that we are saying are our main sort of in-year priorities to help deliver the 5-year kind of priorities? How do you take the 5 years and break it down to a 1 year? There's a recognition, though, that that is not the totality of the business that we're currently doing. So if you think about all the CAMS transformation program that we've got going on this year, if you think about the rollout of our new System 1 EPR, if you think about environmental sustainability program, there's a huge raft of organisational kind of sort of projects that are also kind of going on simultaneously to the things that we're saying are our sort of true north for the year. So what we're trying to do is just get a way of kind of organising it so that we can see those things. Otherwise, I think if we don't do that discrimination, what tends to happen is everyone starts putting all the organisational projects as a strategic priority, and then suddenly you end up with a list of 12,000.
It's helpful. So it's more the sort of BAU stuff and stuff that's
yes, so the way we try to articulate, so you've kind of got BAU at the bottom. So that's just how we're doing what we should be doing and doing it well and effectively. You've got your organisational projects, which we've got an SLT session next Friday to take the 80 down to something that vaguely looks a bit more kind of sort of manageable. And then you've then got your sort of strategic objectives that sort of sit above those, which are the kind of the sort of the true north metrics that I would be suggesting that as a board, those are the ones that you really want to be scrutinising in depth, and then have regular updates around the organisational projects as well.
probably just helps when we see it populated. It would be a later sense. So, yeah.
Thanks, Stevie and Colin, about that. I think you full support from the board and work with the senior leaders to ensure that we do the right filtering and prioritising, for the objectives and targets that we have for next year. And you've given us a degree of confidence that the strategy does fit quite a lot with what's coming down now from NHS England about performance and what we need to be prioritising. So thanks so much, Dan.
Building on what Colin said, we've been very mindful throughout this process of the trap that organisations can fall into of developing a new strategy and then returning to business as usual.
Yeah.
So alongside the delivery mechanism Colin's described, the engagement work continues. So the event in May isn't an opportunity for us to congratulate ourselves on producing the strategy. It's part of that ongoing engagement work with staff, with partners, with people who use services about actually delivering it. And that will be a springboard for a whole programme of activity that will happen over the spring and over the summer. All the more important to do that in a resource constrained environment, all the more important to do that in the light of feedback we've had both from staff and from patients about their experience.
Thank you very much. Good. Lovely. So if we move on to delivering high quality consistently. We've got 5 papers, 5 reports from the Quality Committee of GDC.
So obviously this is a condensing 2 meetings. We've had 2 meetings since the last board. It's read. I just want to record no escalations to the board, but obviously and no no change the risk scores that Quality Committee has particular responsibility and focus on. But as always, huge ongoing challenges across the systems in terms of maintaining quality. We noted partial assurance across our domains of safety, effectiveness and experience. We're going to talk in a minute about the work on community mental health services, intensive support and the assertive outreach review, which is was rightly received and scrutinised in depth at the Quality Committee. That's happening today. In terms of safety, you know, that continuing focus on suicide prevention, ligature, awareness training and enhanced therapeutic observations, we very much welcomed that. On effectiveness, we had a very comprehensive report on that, and we're pleased to see improvements, particularly on the PROMS scores, and the very much welcomed work that's increasing around health inequalities. And on experience, although we noted that the target for complaint response time was not met, we did note the significant work that's ongoing that we hope will result in improvements here. We were very pleased to see the Learning Disabilities and Autism Improvement Standards report and recognise the really excellent area and the importance of, as for all things, improving data reporting, quality of data, seeing an increase. We would very much supported there, asked for an increase in resources within community, LD teams, and the involvement of people with learning disabilities and autism in decision making. On workforce, the turnover rate has further reduced to 13.2. The vacancy rate's 9.2%, and the appraisal compliance remains strong, but agency usage is up, especially in Brighton services. And as we've already mentioned, sickness absent is now at 5.7%. So we've discussed that for some time. On the provider collaborative report, again, I think that the quality of reporting is improving all the time. The main issues discussed there in terms of adult provider collaboratives was the impact of decommissioning on women's enhanced medium secure services, the increase in demand for medium secure places for men, and on children and young people, we talked about the lack of capacity and medical workforce gaps. But overall, we noted that access to CAM services has increased. And then finally, just wanted to note for the board on the really excellent reports on gender, ethnicity and disability pay gap, that we've seen a reduction in the gender pay gap. Mean is now at 10.3%, down from 11% last time. Ethnicity is now at 1.1%, down from 4.6% in 2023. And the disability pay gap is now 8.7%. So the ethnicity pay gap shows the greatest improvements, followed by gender and disability. And we very much hope that that will continue in that direction. Thank you very much.
Thanks, thank you, very comprehensive. Yeah, Ganesh.
Sorry, my hand was up for the previous item, as was Simon's, and I think both of us got ignored. So two things, if I may, going back to the strategy question. I mean, one is that it would be really helpful for the board to know a list of acronyms, because they keep coming up and sometimes I'm completely lost as to what the acronym means. But more than that, I think what I really wanted to flag up was that I understand that there's a launch of strategy on 5th of May in Amex Stadium. Is that correct?
7th May, Ganesh.
Okay, I mean, I would like to have my sort of concerns minuted, please, if I may, because I would really like to know that under these kind of pressing financial times, how much time, effort, energy, and money we've spent on developing strategy, and now we're going to launch it. You may recall, or the board may recall, that when we had the award ceremony in Brighton last year, lots of staff had made their unhappiness quite clear that we were spending money for awards. My own view is that we need to celebrate achievements, and therefore that's a kind of completely different line. But having to launch a document, it may be important for the trust. I feel very uncomfortable, and I'd like that recorded, please.
Okay, Dinesh. Firstly, I maybe need to visit the opticians again. I can't always see the hands up on the screen, so
No, don't worry about that.
just will come Simon in a minute. But just on that, I mean, Dan will want to it's just there's always a tricky balance here between being, with all the financial constraints and the difficulties, but there was a time to step back as well and be proud of what you have achieved, and also add clarity to where we're going to staff and our partners. Our partners expect us to be, and they really do. They think we're a high profile. We have to keep that profile up, and one way of doing that is to do a launch. And I will say one thing that I've often said that Usman, great finance director, but we have a financial constraints, and it's going to get more intensified as we go forward. But you always, Usman, you plan for things like this. So they're in the budget, and we've got to get the balance right. And I personally think on this occasion we've got the balance right. It is important to celebrate and to profile that the huge work we've done on the strategy, but it's also to take people with us. But we will record your concern, because it is right. Like Jane was saying in her report, we're stewards of public money, and we've got to account for it. But Dan, did you want to add to that?
I mean, I just had a couple of points, Jen, and thank you, Dinesh. It's a helpful challenge. I would say two things. One, a strategy is not a document. It's about defining how we use our resources to improve quality and improve the care we provide to patients. Second, as I mentioned just now, the event on the 7th isn't about congratulating ourselves that we produced the strategy. It's part of that ongoing engagement with all our stakeholders about how we deliver it, how we put it into practice to improve quality and improve the care that patients receive.
So we'll need to close
I mean, I don't have a qualm about that. I understand where you're coming from, but I am looking at public perception. I mean, why could we not have this launch at the annual general meeting of the trust? So you've noted my concerns.
Yeah.
That's very kind. Thank you.
No, that's perfectly okay, Dinesh. And I say, like to raise it. We need to move on, but I want to take Simon. I know Anil wants to come in. Simon, I'm sorry we missed your hand.
Don't worry, it's moved on. It's not important, honestly.
Anil.
If I just pick up on Dinesh's point, not so long ago, I was with Dinesh and I outlined at board and then at other meetings my apprehensions around spend. At the same time, I'm conscious, and so remind me, in our staff survey, there are two features that our staff have fed back that really stick out. And one was that compassionate leadership was above the average, positive. However, that didn't bleed into them feeling that we are a compassionate, inclusive organisation. But secondly, and moreover, they are telling us, are they not, that they have not felt historically as involved in the change journey as they would have wanted and hoped. And it's for those two reasons, or given that feedback, that on balance, I actually think what we're proposing to do at the Amex is the right thing, or despite those concerns I had. So just
as we were saying, thank you, Nola. It is a balance, tricky balance, and you need to have these discussions. So that's thank you very much, Anna.
Apologies for hijacking Anna's item.
No, so any comments, questions on the reports?
Are we going back to Anna now?
Yes, we are, yeah.
Yes, please. If that's okay. This comes with the important preface that it's not going to curry favour with anyone or win me any friends, but nonetheless it's important. Anna, you quite rightly talk about sickness absence being 5.7%. I appreciate that's not out of kilter with the entire NHS landscape. At the same time, it is twice as much as the next highest sector in our economy, and over twice as much than some public sector groupings, for example, teachers. Last year budgeted substantive budget for staff was just over 300 million. 5.7% equates to just smidgen below 17 million. And yet, again, we are not talking about labour productivity. I can't see that. Not with a cudgel, but rather as a way to ensure that as a trust, we are spending our resource prudently, that people are working optimally. I think that's something perhaps we need to pick up, either quality or pick, especially in light of the fact that, remind me, make tens of millions of pounds of savings.
Sure, you think about this all the time, and certainly for me and I had catch up last week, and one of the things I raised with her was this very point. And I, just looking outside of us, I think one of the interesting things that I picked up on from other places was that we also need to think about staff presenteeism. So not just about absence, but about, presenteeism, and that became a real focus during the pandemic, I think. But I think some of the learning from that we need to now think about. We've got a clear picture of why people are not coming into work, and sadly that's anxiety, depression, stress. I think we need to have a bigger conversation about people who are at work but not necessarily functioning optimally because of the pressures. So this is not just about 5.7%, I think. So thank you for raising it. I can only assure you that a quality committee, we are looking at it, but perhaps we need to start to think about it in a different way, and your challenges are very helpful.
Yes.
So
yes, please.
Thank you.
Yeah, sorry.
No. So I agree with your points, and we're looking at both internally and externally across the system, and looking at how we can both learn from what we've done well historically, how we can deliver programs of change, knowing that they will impact on people's wellness, and actually how we do that in a trauma-informed way. We were talking earlier about the strategy, and Kathy, you mentioned the difference between the strategic objectives and the directorate priorities, and wellness and well-being, which is sickness absence, but more than that, is absolutely our people and culture priority from a directorate level for the next year. We've stepped up a number of programs looking at our workforce and how we best utilise our workforce in a compassionate way in order that we keep people well at work, and that's aligned to the activities related to the staff survey, the activities related to our delivery of our strategy, and the activities related, and Anna, you touched on our disability pay gap and some of the activities related in there. So they're all intrinsically linked.
Thanks. And of course, it's linked to how competent and how confident people are in their roles. So we have recently stood up a ward managers module, and more recently a matrons module that allows the clarity around what the key components of those roles are and need to be. That is aligned with the organisation strategy ultimately. So I don't want us to lose the link between and the lens of what productivity can mean to different people. So that productivity of a ward manager or productivity of a matron also needs to be supported by really clear training and guidance as to what that role is and how that role best delivers. So I'm really pleased that we've got ward managers and matrons modules in place. It's a small example of something that's far bigger issue, but it's a great place for us to be starting.
We are so reliant on our middle managers, senior leaders, and if you're studying some specific focus training and development on that, that's going to be really good. Very much support. Yeah, we need to move on. But
You mentioned, and it's right to say that on the face of it, ethnicity pay gap has been narrowed, but there is one block, a cohort of human beings that it's not moving for, and that's Black African and Black Caribbean staff. It's just not. What more, I suppose, can we do to help support that cohort and address that issue?
And I think that starts with increasing our champions in our networks, and actually not looking to ourselves to answer that question, but to working with individuals and that network specifically to understand what more we can do. And that's aligned to our EDI improvement plan and the actions associated with that.
And FUMI's got networks, because one of the first questions I'd ask is, well, where have they got this right? Where are they doing well across the country? And what are they doing? What specifically are they doing that we have to learn from them? But FUMI's part of the network.
Absolutely.
It's the NHS employers. That's what they're there for. Anna.
So, I mean, and obviously we talked about this as well, but I think the for me, the progress is in that we now know this. We now have the data, and that's our starting point. So I think the clarity of
and I agree, forgive me for being unfair, but it's cold comfort for those who, perhaps for including broader societal issues, facing this reality. But it's a positive, I agree.
But I didn't in any way, by mentioning the headline of 4.6 to 1.1, in any way forget that there are huge disparities within those Black and minority groupings that we absolutely need to.
Well, it's more specifically, it's Black women, let's be frank.
Yep.
Very much. We're going to move on to future announcement to have Claire Tanner to come and one of the roads a little bit flowing behind, but very, very big reasons. Then we can have a little bit of session.
Yeah, of course. I will.
Afternoon, Claire. Welcome. Thank you very much. Deputy Chief Medical Officer. Yes. Congratulations, still in order, isn't it? I think for that. Yeah. So, Claire, please, Community Mental Health Services Intensive Support and Service Outreach Review.
Yes, I have. Thank you. So I will take the paper as read. And thank you to Teresa for supporting the paper. The context of this paper is following the tragic incidents in Nottingham last year, which I'm familiar with, which Valdo Calacane unfortunately perpetrated an act of violence against 3 people who died and seriously injured 3 others. There was a special review of Nottingham's health services. Following this, there was a requirement for the ICB to provide a return. This gathered data from local community mental health services around our readiness should we have a patient who matched a similar profile to Valdo Calacane. So a similar profile would be people who had difficulty engaging with services, and also people who had a history of aggression or violence to other people. The return identified some areas of partial assurance, and the board has already had a paper in December which has looked at some of those areas of partial assurance. We have had additional information in February of last year that has come to the board requiring further actions of us as a trust. These include things such as good information sharing with other agencies, reducing our out of area placements, some things which are already on the trust's agenda. And the task and finish group, which was formulated last September, has been focusing on working through both the areas of partial assurance and the additional actions that we have been given since that time. The task and finish group meets fortnightly, and I'm here to provide you with an update on how far we've got with that work. At point 2.1 of the report, there is a table, which is probably the easiest thing to reference. It's RAG rated, and I'm not proposing to go through all the green actions. The green actions are completed, and therefore there is assurance over those actions. I'm going to talk about the 3 items that are either amber or red on the report. So the first item is the active engagement policy. A recommendation was made by the Task and Finish group to amend the active engagement policy to assure ourselves that patients who have difficulty engaging and do not turn up for appointments would not be discharged without further clinical thought and risk assessment being put into that process. It was taken through the policies subcommittee, who recommended a full review of the policy. Therefore, that action isn't completed. However, the Task and Finish group have written a safety bulletin to ensure that the learning from the incident in Nottingham is shared with all clinical staff. So although it is not completed, that is on track for completion. It's probably worth noting that a group is being formulated now by our interim Deputy Chief Nursing Officer to look at the policy and update that with appropriate hastiness, but thoroughly. The second point is the medically led audit. The audit was to identify the exact number of patients that we have in our community mental health teams that fit a similar profile to valdecalicane. We have a rough idea because we've obviously had some help from colleagues with in the performance team with data extraction. However, we need to do a manual audit of all of the notes that have been identified to identify the true number. This has been delayed. That's due to a lack of available clinical time. The audit requires a clinician, and it has to be a clinician, to go into each record on care notes and look at the record. It takes about 10 minutes per person, and we've got somewhere north of 200 people to look at. So that's quite a labour intensive process. We are optimistic that that will be completed by the end of April 2025. We've now got some additional support from the audit team to ensure that that happens. The third area of partial assurance is around care plans and risk assessments. There is one item in that box that is completed, so I won't talk to that. The part that is on track is the new proposed care plan functionality in our new electronic patient record. And I've just realised the report, sorry, I'll let an acronym go through. The new electronic patient record care plan was ratified at CODA, which is Clinical and Operational Delivery Authority. So that is essentially the clinical group that's looking at our digital work to implement System 1. So those are the areas that are not yet complete. The Task and Finish group continues, and those will all be completed in due course. So in summary, the Task and Finish group is continuing. The actions are on track or completed. There's good oversight. There's good assurance that the outstanding items will be completed, and there will be a further report going to Quality and Risk Management and then to Quality Committee in July of this year. Thank you.
Thank you very much. This is all about assurance, and you've given me lots of assurance on this and a really difficult situation. And I'm sort of quite pleased that it had to go through the ICB. Actually, it's important that boards get a real good understanding of our specific risks in mental health, and this is one that's very much aligned to mental health, I think, specifically, and so it's quite good that they have oversight for that. Thank you very much for your clinical leadership. Before we throw it open, Oliver, is there anything you want to particularly add? I don't think so. No, Anna, I'm sorry.
So I mean, and obviously this has come to Quality Committee. The thing I just wanted to bring to board was the issue of, because obviously we know that the ATS is, a huge amount here.
Yeah.
We know the pressure around the.
Yeah.
I suppose for me, the question in my mind, because I think it's a really excellent piece of work. I think it's well thought through. It's been delivered really, with really high standards. And you just, as Sean says, you've given us assurance. Do we have the resources in the neighbourhood teams to sustain this over the long term? That's what's in my head.
Yeah, and that
can we, given all that's going on, can we make sure that investment in neighbourhood teams continues to to happen at the level that we need it to in order to make sure this never happens in our on our patch.
So I think that's a really pertinent question, and that's something the Task and Finish group has spent a lot of time thinking about. There is a systems bid that has been put in for additional resource for workers who would assist with engagement. We're expecting the outcome of that in June. We are not banking on that actually coming, one cannot bank on things that haven't happened yet. So there is discussion in the Task and Finish group recognising the competing demands on the neighbourhood mental health teams over how we would overcome that. We haven't reached, I'd be honest, Anna, we haven't reached a formed position. However, that is very much a live topic of discussion because, as you say, the neighbourhood mental health teams have a lot of different competing priorities, and this is very, very important to get right for this group of patients. It goes very wrong. Yeah.
Yeah, can I just we think about the case, the specifics of the actual case that prompted this. I think what that highlighted was effectively a patient with significant health needs, evidence of address to others, Boston system, and the needs were not taken sufficiently enough to for them to maintain their involvement and clinical oversight. I would love to say that we can stop incidents like this happening. I'm afraid that's just not possible. But what we do need to do is to make sure that we have made every effort and we have clinical systems that are as robust as possible. So there's a short-term piece of work that we're having to manage, which Claire's just outlined. The medium-term areas of effort are on our redesign of our clinical model, our CPA approach as well. In particular, thinking about ability, the way we define caseloads, the way we also have an electronic patient record system that has a modern approach to risk assessment. Also allows us to identify whether patients have follow-up. One of the biggest risks in an ATS is when patients are lost to follow-up and effectively repeat care. And so we are changing our QPR to look specifically at those patients that have not been seen for 6, 9, 8, 12 months because they are a very interesting and important group to get hold of. The other issue that we've noted is that whilst our GPs have a very high level of recording around the diagnoses that we make, we really struggle to identify patients and get by diagnosis. And that's why it's manual surgery. An awful lot of work that we need to do in order to assure that we minimise this.
Thank you very much. We'll take Teresa and then Kevin, and then we'll close for a break. Teresa.
Thank you. So Oliver's covered most of what I was going to say, but to add, the EPR and an effective EPR is going to be critical in this. So that's one thing. And then the second is, and you'll see it in that last slide of the conclusion, that the oversight group will be tasked with agreeing an effective auditing methodology in April 25. So traditionally, I would be thinking about that as our internal quality assurance reviews. But actually, we now need to move on and look at that through the lens of continuous quality improvement. I need to stop pointing at you probably when I say continuous. It's going to get a label. But from a continuous QI perspective, that also will enable us to go from task and finish, which is the approach that we've taken thus far, to the oversight group, to actually what does continuous quality improvement look like within the learning from this review. And organisationally, I feel really confident that we are developing an architecture that allows us to do that with far better assurance than we have been able to until now.
It's really good to hear. Kevin, last point, please.
Yeah, sure. And both my questions have been answered. I was asking about the resource. I was going to reinforce the point about the resource and also progress with the strange situation where we didn't have our own diagnoses and had to go to GPs to find out what our own diagnosis are. We've had those updates and that's great. So can I say something positive, if that's okay? I'm kind of repeating what I said in quality, that I think if this had come in 3 years ago when I first joined, it would have been a very spasmodic and siloed response to an external shock, if you like. We have to do this thing. And what we would have got probably been quite a siloed response in terms of planning. And what I love about this is that it is integrated, it is comprehensive, it weaves into organizational processes, it aligns to things we're doing anyway strategically, and the EPR is in there. So again, my positive point is that from a terrible incident, we haven't overreacted or just gone, let's do this and this. We have really woven it in our responses and come up with an integrated response. So thank you for that.
Well said, Kevin, and thank you very much. That's really good to hear. We'll close on that positive note. We're going to come back to be a partner. Is the section next. So I'll take a break now. Okay.
Nice to see you. Jack, I'm really sorry about my.
I've got things happening. It's a statement of fact. It's true. We can prevent it. It's a young man known to our services killed his dad. He's 19. His dad was late 50s. Killed his dad and injured his sister. His sister ripped by that mum.
Okay, welcome back and thanks very much. I think that next with partner. I'm named Brian from our staff and it's a charity committee report. And I would have normally chaired the charity committee, but that was the day that we were called up the leadership of NHS England. And Abiola kindly chaired for me. So Abiola, the exec responsible for this, is colleague. So next to you, Abiola.
Yes. Hello, thank you everyone. So we had the charity committee meeting. On third. One of the things that I wanted everyone to know, it does say that Usman and then there was another change that Colin wanted to point out.
Just under 1.1, it says the strategy was approved by the charity committee, just to know that it's supported by the charity committee because it's coming to the corporate trustee meeting that we have next Thursday.
I'm taking that most people have read the reports. I'm going to take that as well, but it was a good meeting and if there's
anything, Colin, for your point of view? We're taking it as read, and if there's any comments or questions, Colin, anything you wanted to add?
No, I think we kind of transacted quite a lot of business in the meeting. There's quite a focus on the strategy with some good sort of scrutiny from colleagues. Don't want too many spoilers because otherwise we'll have nothing to talk about next week. And quite a lot of focus in terms of really doing some testing around some of the financial kind of expectations for the trust. I think Nitin in particular was really kind of scrutinising quite hard the kind of how far can we go and how quick can we go with some of this type of stuff. So yeah, really useful meeting.
Jill to my left has told me that we made some changes to the on screen here, so we should be able to see hands up now, and I'm not seeing any. So we'll move on. And thank you very much. It's the annual staff survey. No, yes, it's Hillary. Based on the annual staff survey.
I'm turning off the air conditioner because I can't hear with it. It's right above my head.
That was a halo.
And hopefully now, and thank you, Simon, for your comment, you should be able to hear us a bit more. The air conditioning, well, where we're sitting with the air conditioning is going away, but perhaps if everybody could, in the room, just talk up a little bit, a decibel or two would be helpful. Take what's that chair? It's one of those moments, isn't it, where you're all looking amazing. Well, why have they got Hillary here? We're finding out. Okay. Please join us just by John. And Hilary, great to see you. Thank you very much.
Thank you.
Associate Director of Culture and Organisation. But yeah, presenting the paper on the staff survey, annual staff survey.
That's right. Thank you. Do you want to say anything to? Well, lovely to meet everybody. I'm not sure what some of you will be very familiar with the staff survey, and some of you maybe less so. So what I wanted to do is just say a little bit about the staff survey briefly, to talk about our results, and give you a bit of an overview, to take you through the overview that I've given you in the paper, and then to say a little bit about what we're planning to do this year in response to those results. So the staff survey is one of the biggest staff surveys in the world. So really, it's got a fantastic amount of data that it produces, and I think we sometimes forget that sometimes in the NHS people can be a bit eye-rolly about the staff survey, and it can feel a bit of a kind of annual chore. But we're really trying to work on having a different relationship with the staff survey in this organisation. It's very common that we're not alone in trusts have tended historically to have a bit of a transactional approach to the staff survey. So the results come in, and then there's an expectation that divisions and local teams create an action plan in response to that. And then nobody really looked at the action plan very much in terms of them actually how we're delivering against that. And then before you know it, it's the time for the next staff survey. So what we've been working on and thinking about over this year is how do we change the relationship with the staff survey across the organisation. And that's essentially by improving the engagement at all levels with it. So much less of an emphasis just looking at this year's data, but trying to look at it through the lens of what are the trends that it's telling us, and how does that link with the wider organisational strategy that we've developed and our delivery plan for this year. So in terms of what we're doing across in our organisation specifically, what we've decided to do is look at the data together. We've put it on Power BI this year for the first time, so that means that people can play with the data, have much greater sense of ownership of it themselves. And then we're going to bring the leadership teams for each division, and for this year we're going to be doing that with the key corporate teams as well, to really dive into their data and look at what does that tell us about our particular division, and where we're aligned with the rest of the trust in terms of our performance, and where we might have either we're performing really well and there's learning there, or where we have hotspots where we really need to focus our attention. We're also really focused on not creating a separate plan. So all of the work this year will be, we have got a plan, a really clear plan for the first time, I think, this year that everybody signed up to. The divisions are really clear about what their responsibilities are there. And so at those workshops, what we're looking at is what are we already doing, what's working well, where are the gaps, and then we'll be bringing a senior leadership team together in May to think together and share some of those reflections and thoughts, so that we can have much more of a sense of this is just one data set that's useful, but it is just one set of data, and we'll think about that in the context of all the other, particularly workforce metrics, where that's critical. So in terms of our results this year, we knew it was going to be a challenging year. Obviously, we've had some significant challenges, and that was always going to impact on our staff survey results and our staff experience. And in fact, we did some predictions about where we would land this year in terms of the staff survey that were largely accurate. Most of that we were either some of it was a bit better than we thought, some of it, a couple of them are slightly worse, but largely we did expect to deteriorate slightly, and we've either done that for a few questions or maintained in others. We've had a 45% response rate this year, which was the same as last year. So again, we really want to. What we're anticipating is that as we engage more with divisions and with staff on the ground about feeding back what we're doing and how what they've said to us relates to our plan and where the gaps are and what we want to work on, that people will start to see a bit more of a link with them speaking and telling us what they think and what happens on the ground. So really kind of keen to make that improve that link. The key thing to note, if you are familiar with it, is that usually what we get is comparative data for the last 4 years or so, and this year for the first time we haven't got that because of the changes to Hampshire CAMS and Lindridge, and so it's a bit odd this year. Normally we can look back and say this, here are some of the trends, but we've not been able to do that this year because of that because the staff survey centre deem it statistically unreliable because of those changes. So I'm just going to highlight just a couple of the areas that I've addressed in the report. Essentially, I've identified 4 areas where we're above the national average and 4 areas where we're below, just to highlight some of those points. So you'll see on People Promise 1, we are compassionate and inclusive. We're above average in relation to both compassionate leadership and inclusion. And we're also above average in terms of the schools where staff feel that they're recognised for the good work that they do and the extent to which their immediate line manager values their work. And there was a real pattern in all of the data around people's relationship with their line manager, which was generally very positive, and people felt very scored more highly on those. We work flexibly again. In fact, we've dropped slightly this year. We were even higher last year, so clearly we're quite near the top of the range nationally for flexible working. So that's really positive. May have dropped. We have introduced a new revised policy around that this year, and that may have had a bit of an impact. In terms of appraisals, we've worked really hard this year to ensure that everybody gets an appraisal, and that's really reflected in those nearly 94% of people have had an appraisal this year. Where we know we've got real issues is in people's experience of appraisals and see, well, the question is about appraisals, and so we're doing some work at the moment to ensure that all appraising managers have a sort of development workshop to ensure that we can make the experience of those appraisals a more positive one. You'll notice if you look at the national data, in fact, that even the best trusts struggle with this. They score less than 40% in terms of people's experience of appraisal. So it's clearly an issue across the NHS about how we ensure that people get the most out of those annual conversations. And then the other 2 people promises I want to highlight are about we have a voice that counts and being involved in decisions and changes that affect my work and team or department, which again we might be expecting in terms of some of the work we've been doing over the last year that has kind of we've had to largely impose on people. And then the 2 final ones under the people promise, we're always learning, and morale that there are enough staff at the organisation for me to do my job properly was also lower than average. And then I've included some of the work around the scores for the divisional results. So essentially, we've dropped slightly in terms of our overall scores, but our emphasis in the coming year will start to shift. We're hoping people's experience of the staff survey and their engagement in it, and it'll be really interesting to see the key next phase. I think is those trust-wide workshops to really engage with staff around the results so that they have more ownership of it. Stop there. Thank you.
I'd like to give Zoe the execs
Thank you, and thank you, Hilary. That was really clear. I think what is clear is we recognise that we've got a lot of work to do, and we recognise specifically in relation to having a compassionate culture. I think the way that we are approaching the staff survey through a lens of continuous improvement, aligned to the work and our ongoing work in relation to the strategy, is absolutely right, in order that people can see and feel heard and recognise that they have a voice that counts. And I think through that lens, what we can do is actually start to make a difference at a localized level where we need to in order to do that. We anticipated the results that we got, but we do recognise the scale of work that we need to do in order that we make ourselves an employer of choice.
So clearly these results are disappointing. They're not where I would want them to be at all. So I'm going to say that up front. I want to have one of the best staff surveys in the country because I think that impacts both for the people that work for us and for patients. What I also think is that it is really important. We have our new trust strategy. One of our what they're called. I've gone blank. Being the employer of choice is one of the drivers. So there isn't going to be a staff survey action plan. It is going to be incorporated into our delivery of our trust strategy so that it becomes everything we do and it becomes the lens through which we see everything. I think it's important we have really open and honest conversations with our staff about this. And part of that, I think it is the importance of exec and non-exec visits to sites. So I know we've had lots for various reasons. We've had a lot of site visits where people have cancelled, when people haven't been able to go when they're committed to. And I think there's something for all of us to reflect on how we go out into services and we meet our staff and we listen to the whispers in the wind and we listen to what's happening on the ground and then triangulate it with what we're seeing in the reports here. So I think this staff survey is a message to us as a board as to how we go out into the organisation and listen and then act. And it probably links to the next item with freedom to speak up as well.
Kevin had his hand up, he's just gone off the screen, so we'll come back to Kevin. Dan.
I was just going to say that I agree an authentic response to the survey is one that avoids becoming transactional. And it also involves recognising that there may not be a straightforward response to some of the feedback we've had from staff. And I'm thinking in particular about the open text comments, which as an exec team, we've read them all. And some of that feedback is really difficult to hear, but it's really important that we've taken the time to read all of that feedback and to be open to hearing what people are telling us. But there isn't necessarily then a series of steps that we can immediately take as a team in response to that. But it's a really important message we need to get across to staff that the survey results are listened to and are heard by the exec team and the board.
Simon, to then Catherine.
Thanks very much, Sean. I think the question that I would ask is there anything that we can learn from those that are above national average from their free text comments? And are people ever in a position to share that? Because I've often, as you know, we'll talk about, well, is above average, below average an issue and how is it? But I think there may be something that we need to learn because lots of organisations are working with all of the same difficulties and challenges. And I would be interested if there is any national sharing forum, Jane, where you or others hear what people are learning, which is positive, which can help us sort of long jump some of those, recognising what Dan's saying about, some of the issues will be complex and complicated.
So yes, FIM is well linked into those. I came from an organisation that was in the top decile of organisations, and that changed for the organisation when they fully implemented continuous quality improvement properly. That came up from the ground. It wasn't a top down, and it was and the board was engaged in it. It also started to happen when the board really engaged with services and staff. So they were the two really significant things I think that happened on that journey that moved us from being middle of the road to being top of the pack. But so they're the two, but FIM is definitely linked in with the national work and looking for exemplars.
Kathy, and we'll
Yeah, I just wanted to echo the point that Hilary made actually about what leapt off the page was people's relationship with their immediate line manager. People felt supported, they felt the health and well-being was taken accountable to, they felt that. But then there was this wider piece about sort of wider organisation and compassionate leadership scored well, but compassionate culture didn't. So it's really just sort of trying to understand that sort of dissonance really that you would expect if one was really back where you'd expect the totality to be. So there's something about there's some sort of gap, isn't there, between people's relationship, their immediate line manager and their perception of the organisation, which is really good to sort of get under the skin.
Yeah.
We're gonna extend this, I think, a little bit because it's really important. But Jane, on this point,
I think it is really important to know, and this is not about being defensive or making excuses. The staff survey came out exactly the same time as our cases for change and our corporate services review. So you will have people on their day-to-day work feeling things are compassionate, but they will experience my job's at risk and I'm at risk of redundancy at the same time, which would mean leadership is probably not as compassionate. So I think it sits well with the point in time that happened for that staff survey. And I was a bit reticent to say that because it comes across as being defensive when you say it happened that week. But I think it is a reality of the content we were in last year and we will be in this year.
I might be silly that. Anna.
So, I mean, I take that point and we talked about this. I think though for me there's a sort of wider point, and I'm interested to know whether in the kind of, so I think that's the right approach, not to take it not the action plan, but to incorporate it into employer of choice and how we get there. The thing I suppose I want to know is whether the kind of relentlessness of the work, we talk about moral injury, which I'm not sure is a term that people necessarily appreciate or understand, but it is something about the relentless nature of the work of so many clinicians, and the burden that falls on them and what they see in terms of people's lives. That I feel like we need to be listening well to that, and maybe we are, but I suppose that's my kind of question as a non-exec, is to what extent do those sorts of, I mean, it's not quite kind of in the realm of trauma-informed conversations, but it's not far off it. It's something about, are we recognizing that and acknowledging just how difficult people's day-to-day clinical lives are, because they're almost, somebody once described, the NHS as a container of stress, and almost each encounter with very sick patients, staff are taking that stress on themselves.
Yeah.
So how do we have those conversations that recognise that that's the reality of people's lives?
We've probably looked at Teresa and Oliver. Teresa, I know you want to come in anyway.
No, I didn't actually, and I could see that Colin did, but I didn't realise that Oliver was. Yeah.
So what's just update? So I guess one of the other things that we've obviously done over the last year is we've engaged and we've listened a huge amount for a different purpose. And I think part of the answer to that, so one of the things that has come through consistently clearly from all of our staff in every bit of engagement we've done is around really wanting clarity of role. And that is within our gift is to really think about how do we help people to be really clear about the purpose. And Oliver will often talk to us as execs around these sort of mission creep in terms of services and service kind of models. And I think there's something about really hearing that if people are saying to us, we just want to be really clear, what are we coming through, know that what we're doing is a path, then I think that will do us a really kind of great service.
That's really good. Oh, go on.
I was just going to add one other point. It's also the clarity of leadership as well.
Yeah.
And so ensuring that we have a medical profession, a robust psychiatry system, but also the professional leadership review this year, but also seeking to clarify
I think, but what I'm trying to do is take order of, when we got onto a particular topic. I think you wanted to respond to that, didn't you, Anna?
Can I just come back? So I take that point, and I completely support clarity of purpose, clarity of role. That's not what I was talking about. I think I'm talking about how people are feeling about what they're carrying and opening up that up, because I think that's the route, or a route. It's not the only route, but it's one route into compassionate culture. So it's not, I think that the issue of clarity of role and clarity of purpose may come into it, but it's not where the conversation needs to start.
Isn't there a clinical supervision structure?
I was also going to say it starts from the very top and the modelling. So we are the executive of next month starting a reflective practice group, and as I said, I think it is all of these things. So it's clarity of role. It's being very clear about the structure and process we need to discuss. It's about clarity of leadership, and it's also about sort of well-being and self-care, and it does start from the very top.
We have Anil and Abiola wants to come in, but I see the screen. I don't want to get, so let's go with Simon, then Dinesh.
Thank you. I guess I was just going to really endorse what Anna was saying, and recognising also that it's not just what happens inside work, but what happens outside work, and recognising that there is a greater level of concern, volatility that is in the world, which will be impacting on people more generally, which is there in the context of work as well. And so I would really support and say there's something which is worth exploring there and thinking about as part of it. I guess just the context for saying that is when I was at Mental Health First Aid England, what we were seeing was more mental health first aiders saying that they felt that they were being asked to deal with more issues or more in-depth issues, which were not all work related, but the combination of work and external. Obviously, that's 6 months old sort of data now, but I think that general recognition that you can't just separate between what's happening outside the world and what's happening inside the world, and those two things might be particular in the context of the trust. And then the other, to just acknowledge what you had said about the board and NED visits, and just say I want to take a personal responsibility for improving that, and if that can be an action which I follow up with somebody, then please let me know who it should be as part of the minutes to do it. I don't feel I've done enough of a good job in that as a NED yet.
No, that's really good, and I will too, Simon, as chair, and we've got appraisals coming up. We've got a chance to discuss these. I think it was really important. I see the benefits when I go out, and can't always put things right, but at least we will listen. I'm going to just go with the remaining people that want to come in. And Dinesh, we'll go with Anil and Abiola.
Thanks very much, Sean. Simon has made a lot of the points that I was going to make. One question that I have is, do the staff know where to seek help if need be? Are there any kind of occupational health availabilities easily, widely advertised and accessible, or not?
Yeah, Lisa?
Yes, it is. And actually, yesterday I was thinking about a particular staff member, and I thought, I need to remind myself of how I access something in particular. And I looked at my computer, and the phone number is there on the screen. So from an accessibility perspective, and just using my own example of yesterday, absolutely it's there on the screen. Don't know if there's anything else.
Thank you. Thanks, Dinesh. Anil and Abiola.
Thanks, Chair. Just reflecting on what was said, I'm curious to understand whether colleagues think there's a connection between Colin mentioned about clarity of role, purpose of issue, the dissonance that Kathy mentioned around leadership and culture, not feeding into culture, and indeed, Anna, how people feel, and what we see in terms of the percentage. I'm going back to another part of the report elsewhere in job planning signed off. Seems to be lowly at 32%. So good that appraisals ticked up. But if, I don't know, but if as an individual professional, I haven't been supported in understanding what those most important goals are, objectives, how I as a leader can help support my team and others, identifying standards, performance metrics. So I'm less able to do what we just talked about, aren't I? Would that be fair?
I'll respond to the job planning.
Yeah.
So, we're 79%. But as of today, and it comes in a cycle. But we've spent an awful lot of time. But it has meant but first of all, we need to get the lead psychiatrist in post in order to do the job planning. It's a very long. There's a bit of a long tail to this. I quite agree that people very clear job plans.
Thank you.
We do, and backed up by your point about recruitment, we need these psychiatrists to do that at leadership level as well.
If I could, thank you for the report, by the way, what you helped me set out. Sorry, I should have said that. I was remiss in not saying that. Really helpful. Our CEO has just said very openly that it's not what we would hope for, it's not what our ambition is. And our deputy CPO is reminding us of the scale of the work needed to be an employer of choice. And that's correct. I'm just reminding myself, I'm not going to look at Colin, because I always do when I look at this document. It's this, not going to look away from Colin. And it reminds us one of our strategic objectives as being in that journey to be employer of choice is well-being and resilience. And it lists 5 things. That costs money, it takes time. Do you feel that you have the resource, the budget in the next and subsequent financial years to do the work that we have set out as a board that we're going to try and achieve? No, I know his answer. I know his answer. That's why I'm...
I think as a function, we have seen investment both through financial investment, but also through structural change in order to put ourselves in the best position that we can to deliver to our strategy. We need, to the point that Colin made earlier, we've got 81, I think Colin, you said 81, for the number of priorities as an organisation to focus on this year. And you'll have seen from our strategic objectives that the wellness one isn't that, but that has to be a focus for both our OD and culture teams, but also our employee relations teams. So we have within our structure, we've changed our structure, we've received financial investment within our structure, and that remains a priority, albeit a directorate priority for this year.
Zoe, is it enough? Yes, but is it enough? I know there's always, we always want more, but is it adequate in your estimation? You're the expert.
So I think we can change the way that we work in order to make it enough.
Okay.
Abiana, please.
Actually, had my hand and, Jane, nailed pretty much what I was trying to say about the timing of, when this came. You can see that in the report. The one that jumps out at me is, are there enough staff at this organisation for me to do my job properly? And obviously we've just taken staff out. So that shouldn't surprise us. But when we look at, across the board, for everyone, even the best result was less than 50%. And, we were really quite close to near the bottom. And then given what's going to happen in these next coming years, so I just think, for us as a board, for the executive, how is it that when we're telling people, right, we're reducing your team, this is the workload, we have to be, I'm sure we probably are, but maybe I just need a bit more assurance as to how we are making sure that that workload doesn't just stay there while we're taking away the staff and expecting people to do the job. Well, maybe we have reduced the workload, but we're not communicating enough to them that we recognise that they're not Superman, Superwoman expected to do the same workload. So there will be some people on here who are worried about their job, that they were going to lose it, but then there's some people who are worried they're going to keep it, but then have to do everybody else's job. So I think, that was a thing that sort of stuck out for me. And then obviously as the board, this is really helpful for us for when we are doing our site visit, because now it helps us a bit more to know what sort of questions to be asking.
You're absolutely right in what you said. That is the art. That's some real, difficult decisions and balancing judgments that the executive, in particular, goes right back up to the executives, Jane, we're having to would go with it in our financial envelope, and that does have implications. I know, it does have implications, and this is one of them. And we have to step up the focus around our staff. What this organisation, my reflections over the last year, is good at when we're waits in accident emergency or clinically ready for discharge. When we focus in on something, we do tend to get results. And what I want to do is to focus in on this so we can continue with our plans for the future, which also means financial reductions, but keep an eye on the staff, because without that, then we've got problems. But Jane, just to finish up.
Just to finish up on that, I think that they're really good points, because the narrative from government is at the moment is about the NHS isn't productive, which means work more or work differently. And so the national message around that, and we are going to be doing work around productivity and thinking about how, but that might come with some difficult conversations about productivity, but also what we need to stop doing as well. So, and I think they're very live conversations that we're going to have through the year, and have to be very open and transparent about the way we're talking about things, with very clear data attached to it, so that we can defend the decisions we make and the impact on outcomes.
Yeah, and then making sure that meets what we're doing strategy wise, and it's not all driven.
Exactly. When I say outcomes, I mean outcomes for our patients and outcomes for our staff. The way they work, it's a bit of a balance of both, but I think we do need to be aware and cognizant of the very strong narrative about productivity in the NHS staff.
I was just going to close up, but Teresa's got this way of saying, please can I have a last?
So one thing that we haven't necessarily spoken about much today is productivity when it comes to the use of tech. So I was in a conversation with a team member this week who, on one hand, was kind of questioning as to whether they needed an additional member of staff. When we explored what that function was, actually, where that resulted for us was in a place to say, let's have a conversation with Joe Hilda. And let's look at whether there is a different way of us operating that function or more way of operating in this way. That's where we also need to be thinking about in relation to productivity. And I know that we do sometimes talk about that, but I think we need to keep it at the forefront.
Thank you very much. And moving on seamlessly, Jackie, welcome. Do you want to come and join us? Yeah, Jackie.
Hello.
6 month in report, I think. So, very good. Segue into it.
Fits together, doesn't it? Do you want me just to say a few words?
Yes, say a few words.
Yeah, I mean, I think the report's hopefully detailed enough, but I suppose we've been focusing on listening up as an organisation this year and the end of last year. So that feels like it fits with the national direction of travel, that a lot of people are speaking up but not always feeling heard. We did introduce a new electronic way of speaking up, so people could press a button. So you could be on the night shift and you could press a button and you could put in an anonymous concern, or you could put in a confidential concern, and that would come straight to me and I could action that. So the idea about that was to move it away from just emailing the Guardian and creating a slightly more formal structure. To take it more seriously, really. So we were expecting a reduction in the number of people who spoke up, because it was a bit more of a statement to speak up. And we have had that reduction, but it's corresponded with more people maybe going to HR with bullying issues rather than coming to me, and more people going to the equality team about reasonable adjustments and things like that rather than coming to me, which is more appropriate. We call that business as usual speaking up. And then, of course, the big piece has been about organisational change. So as Guardians nationally, we're aware that organisational change should be managed through a HR process, and that includes patient safety, and we've been really clear about that. So the only things I've tried to deal with outside that is where people are commenting on the process itself, where they feel the process hasn't happened or there's any learning for the organisation about their experience of going through the process. And I think for certainly some of the, I mean, I don't know the stats for all of them, but certainly for the corporate services redesign, there was a very high level of take up in terms of business as usual responses, including myself. I was part of that process, and I also use business as usual ways of communicating what I think was working and not working. So until recently, we had this picture that I've just described where things were going in the direction we planned. But the staff survey results have come in, and of course, nothing's dropped off a cliff, but they are continuing each year to go slightly in the wrong direction around speaking up. So we still have work to do. So I think the sort of data is giving us a mixed picture. So I'll leave that for any questions.
So, I mean, I think, you know, actually, I was thinking, Jackie, because if you'd been here in the previous discussion about staff survey, because I think lots of relevant themes came up. I mean, I suppose I think what I wanted to just add was, you know, that particular finding that the most common reason was worker safety and well-being consulted on changes. So, you know, we need to be, in a sense, pleased that we've got a drop in numbers. We've got more kind of dissipation across business as usual functions, as you say, and that they're going to the right places and people are getting the response help that they need. So that's a good thing. But just to, you know, to acknowledge that issue about people not feeling safe. And I think, you know, if you look at the national report, it's all about listening up, speaking up. And how do we get that shift? You know, we've almost kind of got to make a culture shift from speaking bit to the listening bit and doing that in an authentic way. So I think, you know, thank you for all the work that you do in this space. And we learn from you.
Feeling heard's a complex thing, because you know, I spoke up about things that I think might have impacted the FTSE function through my boss, through the HR process, and that was all productive, but they went ahead with the changes anyway. And I think that happens a lot of staff, and so then some staff might feel, well, I've not been heard then, but actually they have been heard, it's just they're not getting the outcome they want. So again, it is also people's expectations about what being heard is. And I think, you know, it's hard, isn't it? Because there will be some changes that, you know, if I was downgraded or something, I'm probably not going to be understanding about that, how nicely you did it, you know. So I think we are working with that reality. I do think that some processes of change have gone better than others. So we've got to learn from where it goes well. And I know we're doing that. And I do hear different things depending on the different experiences. So there's work to do, but we may never keep everybody happy when there's a lot of organisational change. And, you know, in a way, I'm surprised that the results are so good on the staff survey. I was worried that they'd be very, very bad. Yeah.
Ask about the assurance process and the addition of the short verbal report. I wanted to just find out was going to the private quality committee.
Yeah, well, I'm already in quite a lot of public committees in the sense that, you know, I think it was more that, you know, we've had things around detriment and things that are very personal to specific people. And I think there was a desire to be able to talk about some things more confidentially to improve how we think more sensitively about some of these cases. Because at the core of speaking up is confidentiality. And, you know, I think it was a sense it would be helpful to have a private space because all the other spaces like this are public. Yeah.
We're talking about individual cases.
Okay.
And so it wouldn't be appropriate for it to be in the public meeting. Okay. It needs to be in with the FTSE Ned, Anna and Jackie. So it's to protect the people that are speaking up.
Oh, that's absolutely fine. I just thought this sort of report was fairly, you know, anonymous and stuff, but I have said
there are things behind the scenes, aren't there, as well? Yeah.
Thank you for what you've said in your report. It's the second time I had the privilege of listening to you, so thank you. I'm just conflating what you've said with other things that we've talked about earlier on in the board meeting. And this is going to appear like an oversimplified solution to what is an obviously complex issue. I'm not going to repeat those issues because they're plain and obvious, but it seems to me what Jane said earlier, born out of my experience, albeit in different sectors, this board, both executive and NED, communicating face to face with our teams, listening to them, sharing our lived experiences especially in circumstances where we know, don't we, Usman, that we cannot do what we're asked to do, despite wanting to do that. I think that's probably a good way of ensuring that they feel both listened to, and indeed that even though there's no perfect solution, that we're doing the best we can. I think getting out there, that's my shorthand, getting out there more. Just reminding myself of doing exactly that.
No, I think my question is about this working from home, because I see there's, a couple of concerns. In one place it says, some staff left their job because of changes in working from home. There's a new working from home policy. But when you sort of listen outside, in the general media, you sort of hear that everybody wants to work from home, everybody wants hybrid working. Is that not what we're seeing? Are we actually seeing that people want to be at work and they want the rest of their team at work? I'm just trying to understand more. What is it that we're dealing with here?
Yeah, I think the trust didn't have a clear policy for quite some time. So some teams that maybe are not sort of front working with patients face to face have found themselves working from home a lot, and that people with maybe health issues that want to work at home have gravitated to that. And then the trust has set a boundary around needing to be in more, although there are reasonable adjustments. And so some teams have been really sort of very affected by that, and some individuals have been very affected by that. So it's a very hot topic, the working from home issue. People have very strong views about it wherever you go that don't seem to be based in any evidence, but everyone's decided that it works or it doesn't work, or people are lazy at home, or they, and so it's just a hot topic that's come up from different angles to speaking up. But I think sometimes there's also been quite a mechanical approach by managers. So some teams, there's one poor woman who was asked to come in and work in an empty building in the middle of Meadowfield, which is a big hospital, sort of big car parks, on their own on the night shift to take calls from patients that they could have done from home, because the team are trying to get people back into the office. And their hope is if we can get a couple more people in, we'll get you in. But actually, from that person's point of view, it's absolute madness to be on their own in the middle of the night. And this, but there's a kind of, some places are implementing things quite mechanically and telling staff, this is good for you. And they say, well, no, it isn't, I'm on my own. So I think there needs to be some teams as well do that here, where there's got to be someone from the team in every week without thinking, or every day, without thinking, well, what's it like for that person sitting with other teams they don't know? Whereas some teams, they all come in on a Tuesday and they all meet on a Tuesday, and that feels like it promotes something. So sometimes it's just a slightly mechanical approach to things.
So what is it that we have a organisation-wide policy? Everyone needs to be in 3 days a week, or everyone needs to be in when your team's in, or is it we're allowing different divisions to choose what actually works?
Let's ask Mary to talk brief headlines on the policy, and then we can give it to every as well.
Thank you, Chair. And I'd like to bring some balance to it.
Sorry.
So I hear what you're saying. So we have an agile working policy which recommends that people work normally 2 days a week from a trust site. What we recommend is that it's done through conversation, and it varies by job type, aware, and individual circumstances. There is huge amounts of evidence base to say working collaboratively in an inclusive environment within an office space is good for teams. It's good for teams' work, but we do have to work with individual circumstances as well, and there could be very significant health reasons where we need to take those adjustments in place. And I hope that where individuals raise that and the policy encourages them to do so, that we do that in a compassionate way. Where concerns are raised in the approach, then the form and function of my teams are there to help managers navigate those more challenging conversations. But I would hope to bring on the whole balance, that when we have brought people back to work, on the whole, we've done that in a compassionate way, recognising the example that Jackie just gave doesn't sound to have been of such. But on the whole, I would say people have benefited from working in an agile, but with some time in the office space.
But we'll move on. I just want to say thank you for. Actually, when I see you in the office, I'm quite reassured that there's pick up concerns of staff. So thank you for everything you do. I'm sorry to keep you waiting.
It's all right.
So moving on to another one of our themes is what I was food every day is creating quality and performance report.
Thank you, Chair. So I will, happy to know, won't go through every one of the 49 slides, but I will just draw out some key things. I think it's always a good sign that as we've gone through the agenda, we've already picked up a number of issues. So in terms of specific areas of improvement that I think it's just worth highlighting, we've already sort of touched on inpatient delays at CRFD, linked to our BAF risk 09 and the changes around that. But that has reduced to the lowest position it has been in 2 years. It's still over what we would consider the national average, and there are still specific variances within that across the organisation. Highlighting, I think it's worth calling out, we have had a sustained improvement in the West Sussex position. And there are lots of reasons for it. John can, as I do in previous sports, I'll just give a summary of where we are on overall, and then I'll go to colleagues for specifics. I'll leave John to talk about some of the details, but I think we've all heard about the system-wide discharge improvement programme and the work that we've been doing around that, the work we've done in terms of getting the discharge services up and running as well, particularly around West. So, but John will come into specific sort of details. The couple of other areas I wanted to highlight, and this is by no means the report sets out all the areas of improvement as well as all the areas of concern. So I won't go through all of them individually, but just the ones I thought was worth highlighting. And staff supervision, the reason I raise it is we're at compliance again. It's now been over a year consistently that we've been at that. I think it's just worth highlighting the improvement and the work that's been done on it, notwithstanding what we've just discussed through and as a result of the staff survey around the quality of those, not just doing them. But what I will say is, I think given the sustained level of improvement around that, we'll think about whether it remains a core metric for us going into next year, and whether we would actually think about sickness being one of our top level core metrics that we look at, given the issues that we've raised previously. Just to be clear, that's not saying we won't continue to monitor it. It will still be part of our core IQPRs, but in terms of just one of our core dashboard metrics that we the other two areas I just wanted to flag were around the proms. So we've spent quite a long time talking about outcome measures, and proms at the moment is one of those areas that we have the best way to do it. We recognise the challenges with it and the ideal, but I think it is worth highlighting there has been really significant improvement in that, from what was a position where we were in single digits a year ago to now we're at 40% for the prom score. And I think there's been a lot of work around how we've got there. There's still lots of improvement to do, but I think it's been really good example of us saying actually we need to focus on outcomes, how we're going to start doing that, because you need to start measuring those things. Community CAMS, we've talked about 52-week waiting, but I think it's also worth highlighting that the overall waiting list has reduced as well, over 1,100 to 660 over the course of the year. And again, I think that's still high, and we'd want it to be lower, and we'd still be wanting to achieve many of the other core metrics in terms of initial access wait time, but still I think it is worth recognizing that is really significant improvement. I guess two particular areas that flag up in the report in terms of areas of deterioration over a sustained period of time. Risk assessment and care plans we have talked about before. There are lots of detailed works that happens through the IQPRs, and I think it's fair to say there is variation within that, particularly within our specialist division, and there is particular challenges where you've got the neurodevelopmental services within those, and it's not, again, to try and separate those out, but I think we have to recognise that those form a very specific set of challenges for us in terms of how we're going to address those across a whole range of areas. It impacts risk assessments, care plans, it impacts wait times. So we try and differentiate our positions against those. So when you strip those out, we would be in a better position around our areas of care plans. Again, I'll come to others to talk, but Teresa pick up on patient safety incidents. We are overdue in terms of the number of PSI investigations, but it is an improvement on January. So it has come down significantly, and Trish can talk about the work that's still going on, and I think there's been further improvements across the month. And similarly for complaints response, February was a low month for us. I think we had given an early warning that it would be because of particular changes that we've made to SOPs and the processes. I've let Dan come into the details of it, but I think I can give board assurance that while March hasn't fully closed yet, it's technically closed, we still go through the data to do it, but the snapshot is that we will be back at target. The last one, just to flag, and I think John may want to talk about this in a bit more detail, we can all talk about this in a bit more detail, is that we have got challenges, particularly with talk therapy at the moment, particularly it wouldn't be appropriate not to mention it. Our reliable recovery rate in Brighton's dropped to 38%. It's a good reduction. There have been particular challenges around loss of trainees, high staff turnover, and we've had people who've waited the longest have been least likely to engage, and it's been a challenge for us in terms of how we're going to try and address that. The team are working on action plans. We are working with an outsourced provider at the moment to help us address some of the capacity challenges within that team, but that took, realistically, I think we had anticipated that starting faster than perhaps we were ready to be able to do so. So it has now commenced, that outsource arrangement, but it was probably 2 months behind schedule in terms of going live. That therefore has had a detrimental impact in terms of that recovery trajectory. Those, I think, are the key things that I was going to flag. But I'm happy, if it's all right, just to quickly turn, if I go in individual to John first, then Teresa, then to Dan, to pick up their specific points, and then we'll take questions.
A few questions, if you can keep it brief. Yeah. Yeah, go on before we.
Sorry, about the talking therapists, because I noted that have been outsourced and to go for digital approach, and it seemed to be the people that had had to wait the longest that were most likely to disengage. And I wondered if they've been waiting so long that by the time then it was perhaps a different digital offer that turned them off, and whether people who were more newly referred to be more accepting of the digital offer, and to sort of turn it on its head really. Or, you know, what's the sort of response? What's our response going to be to the fact that it's not quite going how we'd like it to?
I don't think it's, you happy with me to? Yeah. I don't think it's specifically about the digital offer. I think it's the fact that they've been waiting a long period of time. So if they had been able to access our service sooner, because we do provide some of our services digitally anyway, but the outsourced capacity was solely a digital offer. So I think it's more about the former. There's a number of issues around our talking therapy services, or a number of root causes for some of the reasons that we're at. So one is an attrition rate in our staffing cohort that we didn't anticipate within last year. Are the decisions that we made to pause recruitment across a number of our services, not least talking therapies, for a period of time, had an impact on that. So there's specific impact on the availability of trainees. So once you start losing people, actually being able to catch up is more challenging. There is, when we look at our talking therapies performance as a trust, it's important, I think, to look at the differences between East Sussex and Brighton and Hove. So Brighton and Hove has always struggled to perform alongside East Sussex. And we did some work fairly recently with NHS Sussex around benchmarking Brighton against other similar populations. So when you look at it against, I think we looked at Bournemouth, Portsmouth, other unitary areas, other populations which reflect it's not wholly dissimilar, and recovery rates are poor in each area. Whereas you look at a more rural population, East Sussex, for example, apologies to people in Hastings and Eastbourne, it's usually a higher recovery rate. So there's a number of root causes within that. But Anne Usman covered the piece around the outsourced provider. And just to remind colleagues, the outsourced provider came about because of the attrition rate in staffing. So in effect, didn't have the staff, did have the budget. How can we buy some additional activity for a quick period of time? Does that help, Kathy?
Yeah, it does.
I will just quickly take Keelan and Dan.
So in relation to the patient safety incident investigations that were overdue, so you can see in the report that we had 35 overdue at the end of January. We had 22 overdue at the end of February. And as I looked at the end of March data, which of course I appreciate isn't in this report, we now have 10 overdue reports. So as Usman said, that breach rate is coming down. And as I have said in the last board, and I will continue to recite this, the most important reason that this is so critical is there are three. So the top reason is I don't want families distressed, families that are grieving, waiting longer than they were told to see the report into their loved ones, often deaths. Second, it delays our ability to take actions quickly, that we're learning through those PSIs, and third, the risk associated with growth processes. And I will often, you would often hear me talking to the teams about those 3 key points, because I don't want this to be seen as a number exercise. Just whilst I'm talking about patient safety and the team, you might recall in the last board meeting, I spoke about the central team that we're developing on the back of the corporate services review. 3 of those 4 new Band 7 posts have now been filled. We've got an interview panel coming up this month for the 4th of 4 posts, which is great because that allows us to move to our new way of operating patient safety function. I think that's everything that I wanted to say in relation to PSII.
Thank you very much, John.
Just to follow up Usman's comments on just a couple of things. I know we talk a lot here about clinically ready for discharge, and it's lovely to see the improvements. I think I just would draw out a couple of points if that's okay for colleagues. So I will draw people's eye to the numbers. So particularly in the Brighton East and West Sussex divisions, the specialist one obviously is more around forensic services, CAMS and LD. So when as a global position, obviously it's significantly reduced, but it's the adult ones that have the impact on people waiting to come into hospital and people waiting in emergency departments. So the reduction is fantastic. It is predominantly in West Sussex. It's down to a number of things: operational grip, oversight, the thorough engagement from West Sussex County Council, which has been a step change, the benefits of our housing programme, etc., etc. There's a number of reasons for it. However, I do think it's important for us all to be cited on the length of the delays that we continue to experience. So the average length of a delay is about 50 days. So whilst it's really improved, it's a very considerable period of time. And we've talked in this setting before about Brighton and the particular patient safety concerns that we have at the county hospital. The length of the delay for patients in Brighton is about 80 days. So there really are some considerable numbers behind the improvement piece. I know you've heard me labour it before, but if you're sitting there thinking, well, why is it not really improving? How does it all stack up? And some of the improvement is within our dementia beds. Again, fantastic for those patients and families, but it doesn't always correlate between increase in or a reduction in people coming into hospital. Just to pick up the care plans and risk assessments piece, Usman mentioned it. Important, I think, to labour the point that in the neurodevelopmental space or in the specialist division numbers, if you extract the neurodevelopmental numbers, the division is very close to being on target. That is in no way to denigrate the importance of people, both adults and children, with neurodevelopmental issues and needing a care plan and risk assessment. But in terms of the volume and the global risk around that, I think it's just important to differentiate it. Happy to take questions on any of the other aspects as needed.
Complaint response times, we were close to 100% in March. I wouldn't want to over celebrate that, because what we need to do is hit the target consistently. What is positive today is that in the Q4 period, we closed 111 cases through early resolution. That's where we're proactively having a conversation with complainants to try and address their concerns that way. And that's the best performance since we changed our complaints policy in April 2023. But we do need to keep on it in terms of meeting that response time target.
Okay. I mean, it's a lot of data and a lot of information. Thank you so much for the execs' contributions.
Yeah, just to thank the execs for for the improvements that they've done. I mean, normally we sort of nitpick and like, why is that not working? Why is that not working? But just to thank you.
Well, thank you.
John and I were talking in the break, and amongst other things, we mentioned my experience of where a document such as this, a report such as this, its absence certainly doesn't allow Ned to nitpick. And it's wonderful to see this, not just its presence, but also its detail. So thank you. Another observation, if I could, and I'm going to be contrary, seems to be that talking therapies is impervious to the action plans and mitigations we have. And I hear what you say, John, in terms of issues around attrition rate and that staffing cohort, staffing recruitment. But this is, I went back in time to look at previous years, but this is arguably so long-standing, it's systemic. So although what you mention is, in the last year, it seems to me that unless there's a step change in our approach, Just doing the same is just not going to work. Would that be fair?
Yeah, it would be, but and there's different reasons in Brighton and East Sussex. So East Sussex has broadly performed, and some of the challenges it has about waiting times have become from A, the attrition in staff, and B, just the volume of activity going through the service. The systemic issue in Brighton is particularly based on the population. So we know that with the younger population, we've seen higher numbers of people come into the service and then not complete their treatment. So their completed treatments recovery rates we've never managed to improve that, despite, like you say, the trajectories, the improvement plans, the productivity plans, the outsourcing, the engagement. We can list off a number of actions. It's a systemic challenge. You're right.
But to add to that,
Colin, give us more of an IAPT expert.
you are, so that's what I'm thinking.
So just, do you think it's really important when we're talking about the recovery rates, just to make sure we're all really clear about what we're talking about. So we're talking about clinical recovery rates. So I will, when we have this conversation about what's going on in our ATSs, I will be so excited because I'll say all the work on prompts is working. So historically, so the measurement of it is absolutely everyone who comes into that service completes measures every single contact that they have with us. And you have to make statistical, I'm going to talk about this outside, you have to make statistical change on 2 measures to basically tick the box, be classed as kind of sort of recovered. What we see when we've done deep dives, and we did that, John was right, we did a comparison with services that I used to run. So we did Southampton, we did Portsmouth, we did Bournemouth, we did Blackpool as well, is that you often see that the demographic of the population that you're serving influences the scores. Quite often you'll see a score variation depending on things like deprivation, you'll see score variations depending on age and other factors, which mean that there are certain services that it is easier to achieve a clinical recovery rate than other areas. So likewise, sort of Dorset and rural Hampshire have much better recovery rates than the city, the urban kind of sort of populations. And I think it's really helpful because it really focuses us and recognises that there is a health inequality in our current evidence base for talking therapies, which demonstrate that it is more effective for some pockets of our communities than it is for kind of sort of other pockets.
Sorry, forgive me, that's helpful. But part of before coming in here, I looked at other not dissimilar demographics and trusts, Hull being one, but others, and their clinical recovery rate seems to be ticking up, whereas ours is certainly in that area just stagnating. So practice elsewhere seemingly cutting through those issues that you're talking about. It seems to me. Now, I'm not a clinician, but just
there is variation. There is absolute variation. I guess if you then overlay it with the other thing you've got in the data is the other metric, right, talks about waiting times. And again, there's loads of evidence that say often the longer people are waiting, the worse the outcomes are. Principally because what you notice is they have higher dropout rates. So you can draw a triangulation. Longer waits, higher dropout rates still affects your clinical recovery rate scores, leading to kind of poorer outcomes as well. So I think there is something really challenging about that particular, kind of really sort of seeing that in those kind of inner city areas where the overarching scores, if you like, are not masked by other areas. So the fact that we still really drive into it is really helpful. Apologies, I could take this outside. We didn't talk to hours about it.
Yeah, no, that's good. And all of it.
I was just going to add to there's also our IAP services sit in a service context. So it is a bit speculative. My impression is that our ATSs, because of the access issues they've had, the cases that IAPs have taken on are probably more complex than I would have witnessed in another system that I worked at previously. So they're taking on more complex cases who are less likely to have a positive outcome, more likely to find engagement difficult. So part of the solution to IAP is actually to improve our enablement health teams, so they are more active and able to engage all of our population.
Yeah, very interesting discussion. There's
forgive me, I'm going to do it for Asia, I think it's called now, just to try and ask questions. Can I just come back to, when I'm on this side, the executive side of a board meeting, the CEO, whatever, I find myself shaking about our strategic objectives, forlornly sometimes, but certainly like Neville Chamberlain. But with this in mind, those areas that we're seeing that are seemingly insulated against whatever we're trying to do, in your estimation, the redesign, both clinical and other, models of care. Do you think it'll address what we set out in our strategic objectives?
So part of our strategic
Big question,
objective
but
is to provide a consistent model of care across our organisation. So our transformation programmes have been designed to adopt the community mental health framework, for instance, which sets out it's in an awful lot of detail. But yeah, I could speak for hours about model fidelity and things like that. But the short answer is yes. If we steer the course and are really, we really are sort of minded to implement what we set out, we will do.
Thank you. Before we go to who's judges on this?
So you've mentioned community, and I'll talk about inpatients. So there is a national culture of care programme for inpatients that identifies 12 key areas of focus. In a couple of weeks' time, we've got a launch of a quality summit for the New King Valley Hospital, and the culture of care leads nationally are coming to join us in that session, which is great. And I met with them yesterday, and it's really exciting work. The opportunity to think together strategically about how we plan to deliver a different model of inpatient care in a brand new building is probably a once in a lifetime opportunity. But it won't stop there, because there's two more strands. The next strand will be, how do we then apply those cultural care principles over those wards that, have got significant estates and facilities issues, for example. And then the next phase is, and what do we learn from those cultural care principles that then influences how we operate every element of the business, finance, estate, workforce, quality, the list goes on. All of that has got some planning wrapped around it in different stages, in different levels of maturity. So my key point there is, for inpatient services, we have a national cultural care framework that allows us at least begin working consistency, starting with our new hospital.
It's just to finally go back to the talking therapy piece. To just sort of to pull it out of the detail into sort of the more of the population health inequalities piece. One of the challenges that we have in terms of Oliver's point around model fidelity is we provide it in East Sussex and Brighton. Somebody else provides it in West Sussex, and the model is different or has been different in each area. So when you look at the offer for the population of Sussex and where we want to get to in terms of our community transformation, it's just another layer of complexity on top of the ones that Colin and Kathy have already described. So the way you've described it as a systemic challenge, I think in Brighton is absolutely right.
ICP who are caught up lots of other authorities at the moment about commissioning and having control over the pathway would be very helpful.
Yeah, actually, I think my comment's going to even add even more complexity, unfortunately, to to the model. Because if we are saying that there are people in a certain area who are more complex, and we know this, but then we've also got on the other side that we want to have consistent model of care, which obviously works operationally, and it works to make sure we've got quality. But actually, if that means that these people continue to not have their needs met, so yes, we want uniformity, but is there a piece that where Colin was saying, well, actually, for certain groups of people, there is a percentage recovery rate. Is it that we're supposed to be looking at what that percentage recovery rate compared to ours and how we shift that so that then everybody's recovery rate is the same? But then that means that we'll have to change the treatment. So, for instance, somebody might need 5 days of talking therapy or 5 sessions, but then somebody else needs 15 because it's just more complex or they're coming from a different demographic. So I'm just trying to understand how our move to a more consistent model of care doesn't exacerbate the health inequalities that we're already seeing.
So I suppose what IAPT is excellent at doing is delivering a very large number of a very tightly defined interventions. And the neighbourhood mental health teams are much more flexible, so they're much more patient-centred, much more able to give a much more holistic and psychosocial package of care to individual people. It's quite interesting. It also makes me but that's not to say there aren't issues. So with the launch of the patient care evaluation across the framework, what we identified in that data pack was the recovery rate for people from a background is just the same. But what we're we need to check is, are the access rates equitable? So we can get people in, but can we, so that's where we probably do have some work to do around the
Look, we've got plenty and we've got the finance law. Move on this is the finance. Anil, sorry, finance.
I'm going to delegate it to a much more knowledgeable colleague here, Abiola, because I was on holiday and she kindly stepped in. So thank you, Abiola. Osman was happy with that.
It's great chairing. Do you want me
My
to just?
computer's just gone off because.
Oh no.
No, that's fine. No, you.
Sorry. I'll just quickly cover it off. You've got here the month 11 finance report and big summary. My computer's also shut off. I'm going to do this all by myself. It's all gone. So there's nothing really to report beyond what we previously said. So at month 11, reported that it would achieve its break-even position. At the meeting that we had, thank you, we discussed that in high level, and it was draft, I should just be clear, both the capital and financial plans for 25-26, which we then subsequently had conversations about through our extraordinary board meeting that was held to sign off those plans. There was an update about the CDH, which we'll also give here later. And there were a number of updates around commercial developments that we will also give in the presentation due to their nature. In terms of the month 11 finance report itself, I'll just take it as read. I don't think there's anything else to say on it that has not already been covered in a number of meetings. I think the one thing I say that just to highlight is our savings program, our CIP program, was on track, delivered as we said, and I think that's a really important thing to note because that was a really significant change program, and I think that's the thing to highlight. It wasn't about the sort of finances, it was about a level of change. And I guess it feeds into all the conversations we've been having today so far about where staff are, about the results from the staff survey, and recognizing that it was difficult as we went through that. And I guess I'll just use it as an opportunity to say, I think we have to bear in mind that we're going to have to go through significant level of change again this year. And so I think we're going to have to be really realistic. Yes, recognizing the issues, it was work that we're going to do, but that it's still going to be really tough as we work through this. And I don't want to speak for the whole NHS, but I suspect it will be an issue that is NHS wide, not just for us, as we all go through the sort of various levels of change programs required in order to live within the means that we have. I think once we get to that point, we will be in a better place, but it will take time, as it has done for us to get there. But I think, as Sean alluded to right at the start in his chair's report, the fact that we started earlier means that the distance we have to go in order to get there, I think, is less than it would have been if we were starting from scratch now. That's it. I'll take questions.
The other thing that I just wanted to, to add to that was, looking at all the challenges that we have to do with our, with our finances, that we did come to the realization that we can't just keep every single time just like salami slicing, taking off a bit here, taking off a bit there. That, as we talked about at the board meeting, we do need to have, at least in the medium term, like what are we going to do that is fundamentally different, so that each time something comes from the centre saying you need to stop this, you need to stop this, we already have our course that allows us to be more efficient. And it is going to involve making some really difficult decisions about things that we don't do. There'll be some things that that we'll continue to do that we might increase, but there's just something we're just going to say, this is not on brand, this is not what we're trying to do with our strategy, and it has to be strategy driven and not finance driven. But we, just to prepare everyone that does need to be something that we need to do, so that we're not continually salami slicing.
Good. So thank you. We'll come to Anil. I just wanted it's pertinent, I think, if you like to say, to acknowledge the change delivery program is delivered on track, and I will say the break even as well. I think to acknowledge your leadership of that and your team, clearly led by Jane, and the clinical leadership as well, because it's it's right across the board. And I've seen you all work really hard on doing this, and taking decisions, agreeing, working out all the possible things we need to do. Yes, but Abiola, you're quite good reminder that there's more to come. But I think will be a base of confidence that I know that there's implications for staff, so the results, etc. But the basis of confidence that we did achieve last year, and it really is an achievement when you look around organisations of NHS trusts and how they've delivered. We're seen as good system partners. Obviously, that when we say we're going to do something, we will do it. So we realise it's going to be hard work ahead. Anil.
Sure. Thank you, Abiola. When you say there's more to come, I think the most conspicuous example of that is that, and I think as a board we need to be maniacally focused on this, we are forecasting to run out of cash Q4 next financial year, and that brings implications that has upon our staff. I think for me, if nothing else, as a board, we have to try and manage that narrative, that reality as best we can. So going back to my earlier point, getting out there, having those authentic, difficult conversations. And I'm looking at myself and Ned, I know my executive colleagues do this day in, day out, but I think there's a call for us, Ned, to do, I speak for myself, more than I have done to date in order to help our executive colleagues around what those implications actually mean for our staff.
Well, I guess just for the record, not to the specific point we raised when we talked about it, I think, was that if we don't deliver our savings program next year, we would be in a position where we would be running out of cash in effect come quarter 4. But yeah, if we don't deliver,
Sorry,
that's important.
Give us the context. Yeah. Simon.
Thank you. I was going to just ask you to make that point of clarity, Usman, so I'm glad, glad that you did. I just wanted to triangulate this back to the bit of the conversation we're having about staff earlier, and just remind ourselves that, yes, we can take comfort that we can do it, but the starting point for staff will often be that we've already done this and already done it. And I just think again, in the way that we communicate, and I know the team will do it brilliantly, but we're not, you don't start from scratch each time we do this, whenever you're doing the change. And I think that's something for us to really bear in mind as we develop the plans and understand what staff are telling us as we go through, and agree with Neil about leaning in, but also doing it very consciously, as Ned's, about what is our role in doing that, so that we do it helpfully and don't try to do things which are the response of the exec and others.
Thank you very much. So finally, it's the audit committee report. Kevin, you're finally stepping in for this.
Now the question is, can I be heard?
Yes, you can. Very clear.
Extraordinary. This is my third line option, quite appropriate with audit in terms of connecting. It's my third device where I connect today, so apologies if I can't be heard. I'm now an iPhone, appalling, which also means I have to remember most of what was said, but let's give it a go. So report taken as read, please. Counter fraud. I think the process and outcomes are good and improving. I think it's we've had a pretty good run of things from kind of from perspective, but also in terms of training and take up, that's going quite well. Internal audit, RSA. When I started on the committee, this was such a bone of contention. The management actions are all out of date, and will they ever get done? And pushing forward deadlines. I think it's in a much better place now, measured improvement. And yeah, and actually it was a rare moment of compassion, I think, when we're looking at management deadlines to get things so much. I'll come back to in a second to the EPR. So that was quite good. External audit progress report. We're still in the foothills of the audit. Obviously, there's a lot of gathering and understanding, and I guess and there's a bit of nervousness, I think, with the new provider. What will they discover? What will they find out? Will they be the same as the old providers? Like getting a new CQC inspector. But I guess my assurance was that if they were uncovering or finding anything out or anything that was worrying in any way, that there would be, I guess, real-time feedback to both exec and via audit committee. And we've got, I think, quite a bit of assurance from them that so far so good. I won't cover was discussed in Chief Finance's report. How am I doing? I'm doing okay. on remembering. Losses of compensations, again, that this has, as I think has gotten better over time. The age of debtors were high, but the seriously aged debtors weren't high, and that is definitely better. And it's just to come on to the, I guess, the IT security issue and the EPR. I think it's written as ESR in the notes. I think we agreed that the EPR, and it probably wasn't brought out fully in the notes actually, the EPR is such a big deal. It is such a huge issue for staff engagement, for staff time, for the IT community generally, that, you know, if we can somehow prioritize that and the implementation of that, and while we will look for assurance around IT security, if you like, that we could, if it's penetration testing, anything we can do to make sure that that is sort of, although important, not getting in the way of the thing itself, which is the EPR implementation. I think we brought that out in the committee, as I recall. That's my, was that even audible? That's my best guess at what the notes may have said, but that's also what I recall. Usman, is it in anywhere near right?
Excellent summary, I would say. I think all I would add is we did spend quite a lot of time. So Paul presented the sort of continuity plan for our digital system that led on to this wider conversation around the level of risk that we may have as we transition into both new systems, the new EPR, and how would the committee take assurance on it. So I think we have committed that we'll bring back a paper on the EPR program specifically to audit, just so that they are clear on what the risk is and how we are managing that risk. Not necessarily around the delivery of the programs, that's an executive function, we'll be doing that, but it's around how are we managing the risks associated with going live around the new EPR program, recognising EPR. We did also, I think it's just worth highlighting, touch on the fact around our DQ, so we also talked about the data quality annual review. And on the headline metrics, I think it's fair to say the trust is doing well in terms of where it comes out against the national benchmarks. But I think recognition that, as we talked to and alluded to earlier on during the course of this day, we've got further work to improve to really understand all of the protected characteristics that go along with our data, so that we can really ensure that our interventions are targeted in a way that gives those groups who don't often get the direct attention they need, get it, and our data points us into that way.
Thank you very much. And thanks, Kevin. Your last contribution. I was sort of thinking that you might pick up your guitar to your left shoulder, play us out.
Yeah, that's how I'm gonna do the outro. I'm gonna play you all out.
Thanks very much. Is there any items of any other business? I'm not expecting any. Good. Well, let's close up and we've got half hour break. And thank you very much. Thank you.
Just I think it's been really helpful to structure the agenda in the way that we have today against our strategy.
Yes,
it's really good.
Then we'll discipline to remind ourselves of the themes. Yeah. Good. Thank you.
Thanks a lot.
Let's keep the recording off. Yeah.
Lovely.